Okay, welcome everyone once again to session 9. And the topic of discussion today is very, very important and relevant for all of us, and that is breaking of bad news. So I'm sure these are a couple of topics we are not trained, but then we have to handle them. Am I right? And most of the aggressive reactions and extreme reactions come after we break the bad news, especially if it is something like unanticipated or things were going okay, but suddenly something came up. So, if I may ask you, what kind of bad news have you broken according to your specialty? If some of you could share your experience. So, for example, in psychiatry, what kind of bad news have you often shared with the patient and the family?
In psychiatry, often a diagnosis itself, uh, because of the stigma, is often a bad news.
Yes.
And especially if it's a young person, it is so the immediate reaction is whether we are looking at giving care for this person throughout their life. So most psychiatric disorders are well controlled with medications, and often they don't require medications lifelong. So discussing regarding the diagnosis with family, especially when it comes to young people, is challenging because that's the expression that comes on their face with regards to.
So anytime I'm sure you must have also seen them denying or not accepting the diagnosis or
Yes.
looking for second opinion.
Yes. It's a challenge. I think the first, especially in disorders where people may not have insight.
Yeah.
With regards to something like schizophrenia or bipolar disorder, I think the first level of discussion is with the family when the person is acutely symptomatic.
Correct.
But at a later point of time, to discuss with the patient, it's a process that goes on for a long period of time, trying to engage, trying to discuss regarding the importance of medications. So it's always a challenge.
I agree. And I can see a couple of answers in the chat box. I'm sure you have some experience to share. So I can see, yes, Dr. Rafiq has written death. I think that's probably the scariest of all. And I know we still have to do that. And especially being intensivist, I think this is something you must be doing it quite often. Dr. Paul has also written death. I agree. I think that's probably one of the most extreme this thing, and we know there will be some repercussions, especially if the family is not prepared for it. Then probably it becomes very difficult to help them accept. Dr. Deepa has written HIV positive. Yes, I agree with you. That's again an extreme, diagnosis. So patients are not comfortable listening to that. Tracheostomy and loss of voice. Yes, I think Dr. Ravi Lakshmi, you have brought up a very pertinent thing. Dr. Asha has written a simple nasal obstruction turning to be malignant disease in a 19-year-old girl. Yes, I think that's something very, very unexpected kind of a thing. And telling them uh, will never get the vision back. Yes, Dr. Raki, yes. Especially in some conditions where we know the loss of vision is irreversible, like glaucoma and other conditions. It's very common. In psychiatry, diagnosis of dementia in older people, autism spectrum disorder in younger children. Absolutely. I remember a family had brought a medical student to me uh, with the simple, idea that probably he was too stressed out for his exams and, admission. So he's looking a little disturbed. So they brought him to me. And it was a very clear case of, OCD. For family to believe that their son, who is a medical student, who has got admission after so much of effort, and suddenly has developed this condition, it was very difficult for them to believe that it could be something. I agree. So Dr. Mini has written maternal or maternal or fetal death. Then Dr. Harimon has written, I do break most bad news, especially in children of parents in oncology. I'm sure, and I know probably it's one of the most difficult thing because you are shattering their hope. I completely agree. Dr. Mini, I think you have raised your hand. You wish to say something. Please go ahead. Unmute your device, please.
No, but I have written that in the chat box, maternal death.
Yeah. And I can see, again, it's a very difficult task when you announce something like this. And then Dr. Lata has written death of a family member. Yes, it's very, again, very, very tricky situation. So if I may ask, what kind of preparation do you do when it comes to breaking of bad news?
First, we will see whether it is justifiable or not, and whether everything was safe from our side. Whether we have done our part correctly, and whether we have misdiagnosed anything, or whether anything has been left, or any omission has come from our side, and whether the appropriate we have communicated to them at the particular levels, each intervals, as and when things had gone bad.
So that means you do that preparation to make sure that when we go and talk, definitely there will be some questions, there will be some queries, and if I have those answers, then probably I can handle that situation very well.
And also the probability of going into such complications scientifically also, the data also.
And knowing some data that can help you prove, kind of justify situation. I agree. Thank you. Yes, Dr. Asha, I think you wish to at some point. Go ahead. Yeah.
Yes, it is not death that we usually have to break bad news about in my specialty. So it's usually a bad disease or a bad diagnosis that we have to break. So that there is no point in thinking back where our diagnosis is right or not. You'll have proof with you. So what I would suggest is, what I would think about usually is, I'll frame myself, spend time myself and analyze how the way I can present it to them, how gentle I can be, and what little positivity I can offer in that. That is the angle I would take before I spread the message across to the patient. I would first discuss with the bystanders first, and then calling the patient in together I would do. That is what I usually do. I don't know if it's right or not. That is the usual way I do. That's the way I would do.
I think that's a wonderful share, that you not only prepare to do it, but you also mentally, get ready to kind of give them a ray of hope, or kind of help them how, the impact of the news can be, minimized to the family. I think that's a very good approach. Thank you for sharing that. Yes, Dr. Harimon, please go ahead. Yeah.
These days, death is not imminent in all the oncology patients. Even if they are going to have death, they continue for about 3 or 4 years, and they become quite close to us also, especially children. So even the parents are in a way prepared for it, unless they come as an emergency, like for example, a leukemia, they're going for crisis and immediately. Otherwise, most of them, they been taking treatment for some years and they know us.
Sorry, I lost your voice.
Which they obviously recognize from the clinical science. I'm sorry, I think my Wi-Fi is poor today. Can you hear me?
Yeah, now we can hear you. In between it was little lag, but I think it's better now. Maybe if you switch off your video and speak.
Can you hear me? I'm sorry. Okay. So what I do is I prepare myself with the
video, Dr. Harimon.
Yeah.
If you switch off your video, I think we'll have more clarity in your audio.
Yeah.
Yes. Yeah.
What I do, is it better now? Okay.
Yes, it is.
I do is I'm even whatever the case was, whether I have been seeing or whoever has been seeing, before I talk, I have been 100% sure of all the nuances of the case. I read the case continuously, because they might ask any question and I should be prepared to answer them very honestly on that aspect. That is one thing which I do. Secondly, I prepare for grief. They were going to be breakdown. They're going to cry, and I have to keep quiet during that time for a long time. Sometimes they may be weeping, and we'll have to allow the emotions to take place. So there's a lot of collusion also. They don't want others to be with them, and only one person should be. Those things are also there. We have to understand cultural values. We cannot be like in the West and tell no, they have to be there. We have to tell and all that. So we're quite flexible in that respect. One thing is know the subject well, how to handle the reaction, and what kind of people we are going to face.
Mhm. Mhm.
That's it.
I think that's a wonderful share, Dr. Harimon. And the things that you have shared, that we need to really be 100% in the know of everything, because that is what our patients expect. That do we know the case? Do we know the investigations done? Do we know the results? Are we very sure of whatever we are going to communicate? And then, of course, as you said, there will be emotional expression. They may cry. They may certainly become quiet. They may act very anxious. We have to allow that expression of emotion. I think I really like this approach that you brought about. Why I'm asking this question, see, when I'm talking to all of you, I'm sure you all must be doing it in an excellent possible way. My major concern is with the younger generation of doctors, because they are the one who sometimes do not know how to handle these emotions. Or sometimes they are not very well prepared when they go and break the news. And if patient family asks something and if they don't know the answer, so either they'll look for some shortcut or they'll avoid answering that question. That is where family starts feeling that probably, my case has not been handled well, when the doctor does not even know what test he has done and what is the finding, and then how do these results corroborate and lead to the diagnosis that he has made. And also sometimes when I say emotions, I always write anticipated emotions. I mean, these are not abnormal. This is a very normal way to react to situation like this. It's an abnormal situation. Serious diagnosis, death, complication. Nobody is mentally ready for this. Trust me, even if at home we talk about something like this, okay, if I die one day, then please make sure that you do like this. I'm sure your family will immediately say, please don't say this. Please don't say this. Because they don't want to even hear that by any chance. Though we all know that's the truth. So you can well imagine who's facing it. It's actually very, very, heartening for them and very painful for them. So why I'm making you discuss all this, I'm sure you all are doing it in the best possible manner. And most of your patients must be really very satisfied with the way you handle their cases. My major concern is because this is where aggressive reactions come in. If you are not able to handle the situation, if you're not able to handle the emotion, if you're not able to respond proactively to the anticipated reaction that patient would give, that is where the major aggressive reactions come in. Therefore, I'm trying to understand from your point of view, what are all of you are doing. Yes, Dr. Menon, I think you wish to make a point. Go ahead, please.
I think along with what Harimohan sir has told, honesty is very important, and we must also recognize the fact that we may not be very clear or we may not have a clear answer to all of their questions. So at that point of time, it's very honest, because the course is predicated upon response to medication and many other factors. So those things we are not very sure. We shouldn't jump in to give false hope. So we must say that, we need to wait and watch. There are these nuances and be honest about that fact.
I think I completely agree with you. In hurry to console, sometimes we say, don't worry, everything will be all right. You will be fine. Don't worry, there are medicines available. There are treatment options available. So they suddenly start having that, hope, okay, it's recoverable. And a lot of time they'll ask you this question, everything will be fine after the surgery or procedure. So there, the major confusion comes in. They think that you are trying to say that everything will be fine after treatment, whereas you don't mean to actually say that, but you are trying to calm them down by giving them some assurance. So I agree. Honesty is very, very important. Absolutely. Yes, Dr. Vasudevan, please go ahead. I think you have a point to make.
Madam, actually, malignancies are quite common when we again there are a lot of malignant thyroid, many malignancies. That's a different thing. But the most difficult one was several years back. It's not now. To tell a parent a 9-month-old baby is having bilateral profound sensory hearing loss. It's a great, because nowadays there is screening tests. Every child born is being screened. But several years back, that was not there. And they were just not willing to believe me. And I had to do, and I come from a small town, and we don't have that BERA or all this investigation. So we have to get it done somewhere else and then inform them. It's very difficult to convince them. You have, they just can't believe that a child will have such a thing, and they had so many questions to ask. We had to be thorough with our answers.
Subject knowledge. Yes.
Yeah, no, and not only that, we had to be, the way we express ourselves, how to go about answering them was difficult, and in a busy OP, it's very difficult. And more than that, one incident is when a doctor was going to be arrested. There was a I don't want to tell about the case, but the doctor was not believing that she was going to be arrested. Finally, I had to talk. I went to her hospital and I said, you have to leave this place, because it was a very, very tricky situation. She went off to Karnataka. She had to leave that place. Otherwise, the DYSP informed me beforehand that we are going to ask that doctor to leave. So when I went and told her, she was not willing to believe it. She said, no, I haven't done anything. This is not my fault. I said, that is a different thing. That is in the court of law, you have to prove. So even if it is not only treatment part, it is in such situation also to break a bad news, it becomes very difficult to a doctor also. They don't believe what we say. Then I had to slowly convince her, keep telling her things. Then it came scrolling in the TV. Then I told her, see, it's coming scrolling. Then she left. And then there were a lot of problems, because I was also informed that my mobile also would be tracked. How many times I told her, don't call me in my mobile, because I would be tracked. So these are things, but they could track where she is. There was a lot of political pressure that she should be arrested. So these are very tricky situations. Breaking bad news is not only in treatment, also in such situations we have.
I completely agree. Thank you for sharing that. Yeah. Yes, Dr. Rakhi. Go ahead, please. Yeah.
Sorry. Yeah, just following through what Dr. Srikumar Vasu said. Even I had a baby who was brought in just about a year old, came with a white pupillary reflex, and it was a retinoblastoma. And to tell them that, it was a nice looking eye, nothing, they can't make out anything, just that white reflex, that's all. But what I need to tell them is that, this eye is you have to sacrifice the eye. And, that eye which is looking normal, and it was so difficult. But what I did is I told them, you go to a higher center, because we are the primary, preliminary tests are only over. So I told them, you go to Aravind, you go there, and I'll write to you which doctor to see. I rang up that doctor and told that such and such a person is coming. And, that reassurance was given to them. Because I didn't have enough time to prepare myself or anything, because the patient just came in as an OPD. And then when they're going back, it's like a totally devastated thing, So I think another thing is that preparing the patient and bystander is also very important. When you are breaking the bad news, you have to make sure that they are also prepared enough to hear that.
Yeah, absolutely. I agree with you. So you can't suddenly break the news. You have to kind of prepare them for
Yeah.
Yeah, I agree with you. Yes, Dr. Harimon, I think you wish to add something.
Otherwise, the bystander will also fall on the other side, and we have to take care of them also.
Absolutely.
Of emotions. Yeah, it happened.
Absolutely.
Especially when breaking an unmarried girl coming with pregnancy. The mother saying the baby, suddenly the child delivering a baby, suddenly the mother almost lose her consciousness, and she also will fall down. It is a very difficult situation.
I agree. Yes, sir, please go ahead. Yeah. Please unmute your device, Dr. Harimon.
Yeah, see, I was only telling about the bad news of breaking possible death. I was not telling about I do a lot of first day counseling for cancer patients. whoever is in my medical oncology department who has already history is done by the medical officers.
Mhm.
It comes to me and then goes to the medical oncologist. I think around two patients I have given now first day counseling in last 2 years. So there are two ways. One is the diagnosis of malignancy for any age is a big thing. So they come with all sort of doom things. You have to tell them. Suppose we are having clinically the stage is convenient and all that. Definitely, like for example, if it's a Hodgkin's, we know it is a curable disease, early stage breast. They're going to live for 20 years, 30 years, normal life. We tell them they're quite happy about it. Unfortunately, when the stage is more, they're going to live maybe 1 or 2 years or 3 years. Then what I do is I collect the positive part of what I can tell them. Like, for example, this person would have come walking. Then I say, he's come walking, he's not going to come in a stretcher or in a, so that means he's going to get the best of the therapy, he can face it. So what is the positive side when you tell it, and you tell it it's going to be in steps, and each one they will ask what is happening in radiotherapy, will I get what all sort of myths are there. So one by one I try to explain, and I tell you go by.
Dr. Harimon, we are losing your voice in between, so there is kind of a gap.
What happens?
Yeah.
Really? Yeah, I think my net is very poor.
Yeah.
That's why I think I'll stop it. I'll write it in the chat box.
Yeah, sure. Thank you so much. Yes, Dr. Lata. Go ahead, please.
We usually encounter a lot of patients, terminally ill patients, elderly who come. So most of the cases, we usually tell them that this is what is going to happen. The condition is critical, and we keep on every 1 or 2 hours, we keep on informing them. That is how we usually do. But 2 months back, I had a case which actually I myself got palpitations that whether I'll be beaten up. That was a case of a 55-year-old lady. She had diarrhea for 3 days. They didn't. They came. I was on night duty that day actually. So around 1 o'clock we had the admission, and orders and all were given. By 3 o'clock I got the call that patient is disoriented. So we had sent all the investigations, but we didn't get the investigations as such by them. So all the vitals was checked. So possibility of hyponatremia, metabolic disorder was considered. Fluid and everything was started. Result was waiting. So she is a lady with 2 sons. So the younger son was with her, 21-year-old. The elder one didn't come. I was there itself. I took all the history. We didn't at that time. So I told them everything at this particular situation. We are doing everything. There's no ICU, but if you want to go somewhere, I can arrange for that also. But sunset will continue there. And 4 o'clock, suddenly patient collapsed. And it's like we did on cardiopulmonary resuscitation, but we could not revive the patient. By the time the elder son came, and he was like, all what happened? So the sister also got really scared, and she was actually shivering, literally shivering. So we called for other staff from the other ward. And when the son came, he saw that we were trying to resuscitate the patient. We tried for around 40-45 minutes. But then I had to declare. So I went and made him sit down, and I told him this is when he is like started crying and shouting. So I just waited. It's like I was calm outside, but I was really scared that maybe it's like he can become aggressive. It's like she was normal, but by luck, by the time the investigation results came, and it's like we had tried to catheterize the bladder. So there's no urine. She was having oliguric renal failure. So because of that or something, all this complication happened and she expired. So that was one case. In so many years, it's like I really got scared that maybe I will get some beatings, but somehow it got solved.
I'm sure, I mean, especially the kind of situation we all are facing right now. I mean, it's very scary actually, and everybody's concerned about welfare. I completely agree. So I can read answer given by Dr. Harimon. In event of first day diagnosis, I try to focus on positive side, like if it is a stage where we can get a complete cure. I just tell them it's a challenge they need to go through as a team. to achieve that. If it is metastatic or diagnosis, on diagnosis, we do not expect a cure, but patient can live for some years with reduced symptoms. I try to point out positive parts of that patient, like mobility, younger age, less comorbidities, ability to go through rigorous treatment if it helps. Yeah, I think that's the way we should be actually balancing between the giving of hope and being honest. I appreciate the way you are saying. So I think when I'm talking about this particular topic, it's not just for you, but basically we are discussing that this knowledge and expertise and experience you have to share with the other doctors when you start your training program. So very honestly, with doctors especially, if you will cover these couple of topics rather than you starting from the basics, what is the importance and relevance of communication and what are the non-verbal and verbal communication, I would suggest that take these 4-5 topics when you talk to when you start your trainings for your doctor. So talk about how to handle aggressive patient party, talk about how to handle uncooperative patients, talk about breaking bad news, talk about disclosure of medical errors. So if you cover these 4-5 topics, I'm sure they'll be happy to attend, because that is one area where everybody is struggling, but they don't know the right way of doing it. See, we all learn, but we learn by making mistakes, and also over a period of time we become expert and experienced in that. But when these young doctors are doing this task, at the early stage of their career, they are not very well equipped with the right understanding. So I would suggest that this should be one of the topics that you need to cover with your trainees when you all start your training programs in this. So another question that I want to ask is, like, how do you mentally and emotionally prepare yourself to break the bad news? What are the concerns, emotional and mental concerns? How, like Dr. Lata said, that palpitation, which you mentioned about it. So that means I'm sure all of us experience some amount of uneasiness and discomfort when it comes to. So do you make any special effort to emotionally and mentally prepare yourself for the situation? I want some others who are not, sharing their thoughts to come up with their thought, because I want everybody to participate. Dr. Rajalakshmi, if you would like to.
Madam, I didn't get the question once more.
I'll repeat. So when you're going to break bad news, how do you prepare yourself mentally and emotionally? Because it's going to be a very, there can be any kind of reaction. We all know there can be aggressive reaction, or they may become very emotional. They may start crying. So how do you mentally and emotionally prepare yourself? Do you make any extra effort?
Yes, madam, we have to, be a little more steely, ready to face the consequences, but at the same time be empathetic enough to break it as softly as possible. So first we have to, make ourselves more, because we have to know everything about the case and be ready to explain things.
Absolutely. So that means you have to do some preparation. I can see Dr. Rakhi has written deep breaths. Okay, that's good. And then Dr. Mini has written maybe involving management. That's what you're trying to say, Dr. Mini?
The hospital management.
They should be informed that I'm going to do this, so they also need to be at standby. Agreed. And then Dr. Mini has also written seek support from colleagues. Absolutely. Yeah, Dr. Tanjil, you had raised hand. What do you want to
I actually wanted to share that I also will take a deep breath, prepare mentally what all things need to be shared in the chronological order, and I'll send one nursing assistant or someone initially to prepare the bystander that I am going to convey certain serious matters about the patient, so that they also will get prepared, and they'll ask the important close bystanders to come near the ICU or wherever it is.
So if I may ask you, and also all others, because you said that you would send your nursing assistant to go and kind of inform them that you're going to talk something serious. So how helpful it is? Does that help? Like you said you are doing it. I just want to understand, does that help?
My idea was if I directly call them and speak to them directly, they may get a bit shocked. That was my idea,
Mm.
but I don't know.
But if
Something like what he meant is something like priming.
I
Yeah,
get,
yeah,
I get that.
exactly.
But priming done by nursing assistants,
It's
the risk
pretty
is
bad.
that if that person goes and says this, and if they are in numbers, for example, if they are, say 5, 10 people, so you never know how they collectively might react. And it can backfire. That's my concern. But I want to understand from all others, what do you say? What is your experience if you tell them beforehand? Because
No,
for
madam.
example, you call them in, maybe one or
Yes.
two people, you make them sit, you talk to them, and then you break the news, whatever you have to share. And if you already tell them that there is something serious to be shared with you, I want to understand from all others. What do you
Break in tighter doses.
He will actually, if you ask me, like, I see most of the cases, what I have seen is the death only. Death on the table because of the comorbidities and things like that. So we definitely will sit with if the surgeon is there, being an anesthetist, I will discuss with them, and we'll finally come in the conclusion, and then tell them because most of the time, like a loose talk may cause problems. Like one person saying something different, so that will be a problem. So after a discussion only, we'll be definitely shocked actually, or it will be difficult for us to convey, but in some way we have to convey anyway. And if it is a sudden death, if it is already a patient is a very high risk patient, we would have already primed them before itself, like these things can happen. In those cases, it may not be having much difficulty. But if it is a sudden death, like amniotic fluid embolism, all those things which we never expect in such a young patient.
Absolutely. So I can see a couple of answers here. Dr. Lata has written, calm myself through my mind, what I'm going to speak. Okay, that's more like, getting ready with even words, what you're going to say and how you're going to say. Dr. Asha has written, take a break, relax, and if needed, attend to them after the busy work is over. So a lot of time, Dr. Asha, people do this, that they would think that I will break the news when I'm about to go or when everything else is over. I'm not sure how much does that really help. Sometimes if we don't tell them, or we wait to tell them, do you think there is a possibility they may think that we knew the information, but we did not share it with them and we kept them waiting? Can there be a confusion of this kind?
No, not at the end of the day, ma'am. I meant if something immediate work is pending, I mean, I'll be more relaxed to talk to them. Maybe say half an hour or not more than that, but then immediate work is there, I'll finish that and then attend. That's what I meant. Not at the end of the day. Yeah.
Okay. So, and then you have written, mentally play out this scenario and be ready for proper response. Okay. So Dr. Vasudevan, arrange a place where we would not be disturbed and ask for 1 or 2 representatives to come. I think that's very important. I think when you do it in an open area, there's always a risk of people who are just overhearing your conversation and maybe interfering or instigating the family or maybe adding, fuel to the fire. I completely agree. Dr. Nadia,
We choose a counseling room and call them and speak.
how many of you have counseling room in your setup? Some of you have it. But those who don't have, where do you do it otherwise? Those who don't have counseling rooms, where do you do it?
Consulting room itself.
I do in
But
my
a chamber.
consultation room, yes.
Consultation. So even that is equally good in case if you have some privacy, some space to sit and talk, there are no unnecessarily people around you. I think that's also a good idea. But having a counseling room and especially with proper CCTV coverage.
And also, as you said, 2 doors.
Yeah, 2 doors. That's what I am recommending now to everybody.
Yeah, sure.
Because you never know how they might
No,
react.
you should not. You should have heavy chairs in it. You should not have light chairs because light chairs are used to the weapon. Yes, it's a fact. And you should not keep costly instruments or TV or something like that, or even ultrasound machine or something which is very costly, because they could damage it.
I think that's also good. I think that's also good. So Dr. Nambiar has written, it is not an easy thing to break the bad news. The people may be aggressive. To keep yourself safe, it is the first priority. The hospital management has to shoulder the responsibility of breaking bad news. So Dr. Nambiar, what you're saying is right, but it's too ideal to be practical. In reality, I think each one of us will have to take the responsibility of talking to the patient. I don't think ever any management will come and say, okay, you do the treating and I will do the breaking of bad news. They'll say it's your job. You will have to do it. Individually, I think we need to prepare ourselves to how to do it. What is the right way of doing it? So I have seen a lot of people delaying it, not doing it on time, or doing it at the end of the day, or doing it in hurry. I've also seen people, asking their residents to do it, not to do it themselves. If you are the consultant and if you have handled the case was under your care, then I think it is the senior most person who should be doing the breaking of bad news, because you can handle. Plus, the rapport that
Experience.
you will have. Yeah.
Experience also counts.
Even patients are more respectful towards senior people. They're less likely to be aggressive. Whereas when a junior resident is doing that, they may think, I mean, it's an assumption they make. He's young, he doesn't know, so he has mismanaged, and that's why this case has got spoiled. That's how they connect the dots. So it's always a good idea that somebody senior should be doing it. But I think all of us have to, learn it properly, know what are the right ways of doing it. And I'm sure by now you all must be seasoned, but then your juniors have to learn by observing you. You can always have your junior residents and other senior residents with you who can observe you doing it so that they can learn from you. Doing mock exercise and role plays is also not a bad idea, although we are not very open to it. But let me tell you, these, role plays at least give you some idea how things can go, in any direction. And I have, personally done a lot of role plays and have seen that sometimes the outcome is very different from what you were expecting. So that kind of prepares you that it won't go the way you think things will go. How a patient party might react could be very, very different. So, I mean, be open to the idea of making them practice and learn how to handle different situations. Then Dr. Vasudev has written, explain to them all that we have done. I think that's very important. Two things that I want to emphasize here is very regularly, I think we should update the family. If you update them on regular basis, they kind of get mentally prepared for it, especially if you have a chance and you know that you can, on regular basis meet and inform the family about what is the development, how the patient is doing, improving, not improving, deteriorating, how the drugs are affecting, all that, and what the test reports are indicating. So that kind of helps them know on what basis you are, guiding them. That is one thing. I would even say allowing the family to see the patient frequently, especially when you know the patient's condition is not good and patient is probably not going to make it. Allowing immediate family members, not everybody and anybody, allowing immediate family members to even see without visiting hours is not a bad idea. Because one, you will see after they have seen the patient, usually they'll have that expression and the body language that would indicate that they have a realization that chances of survival are very poor. You will see even their hand moving on the side of their body, they will be doing like this involuntarily, unknowingly. But that's an indication that they have a realization that probably the patient is not going to make it, because they will try to call the patient's name and the patient does not respond, does not have any, doesn't open eyes. So they have a realization the patient's condition is. That is one thing I say, and especially the residents and nurses working in critical care areas, they need to be more sensitive to the attendance, need to see the patient. One, because probably these are last few hours when the family can see the patient alive. So when you allow them to see, they're always thankful to you for being so considerate. I'm not saying allow everybody and anybody. You can be very clear on it that it's only the first family member who can go in see the patient, but not touch or not, make any kind of noise. Maybe for a couple of minutes, go stand near the patient and then come out. So that way, even they feel very obliged when you are, accommodative to their need to see the patient. And regular updating, I think I completely agree. In critical care, sorry, not in critical care, in like, for example, in emergency department, where you have suddenly a patient who has come bleeding, or the patient has come after road traffic accident, or something where you don't get enough time to build rapport and talk to the family. So I was talking to one of the casualty medical officer. I said, how do you manage crowd and how do you handle, prevent aggressive reactions coming from the patient party? So he said, in our hospital, what we do, there will be a team who will be, managing the patient. And usually, when we take over the patient, we politely and firmly tell the family members that please allow us to settle the patient. And once the patient is, settled, I will come out and update you about patient's condition. So that way they have this feeling that, okay, they are going to now manage the patient, and then finally they'll come and talk to us. And he said we would, invariably in every case, we will go and update the family. So it's very important to tell everything in couple of points. One, in what condition the patient came in. You should have that data. It could be the blood pressure, it could be the respiration, it could be the conscious level, it could be bleeding, whatever parameters you have at hand. If you can bring that up with you and tell them, see, this is the condition of the patient when we received. And then second thing is very important to let them know what all you have done. Normally we think the medical management is our prerogative. What has family to do with it? Why the hell should I be telling him that I've got this done, I'm starting with IV, I've sent blood samples, I'm getting the X-ray done or CT done. But I always say, let the family know what all is being done in the patient care. We do everything, but we don't inform the family. So it is something like winking at a girl in dark, which she does not know. So let the family know that all this has been done. And then kind of tell them what is the, situation right now. And if the situation is not good, be very honest in telling, we have done everything, but we are still, not very sure what it's going to be. So it would kind of prepare them for enhancement. And then when you update them on regular basis, they kind of mentally get prepared that there is the less likelihood of the patient coming. Not all cases are in that situation where they're going to die. It could be even if I apply Pareto's law, out of 10 patients, maybe 1 or 2 patients would be in such a critical condition where the likelihood of survival is very, very low. In those cases, I think building rapport, talking to them, addressing their concerns, allowing them to see, updating them on regular basis are a couple of things that we should very meticulously integrate in our communication with the patient part. So I agree with Dr. Vasudevan's point that you need to explain them what all we have done so that they know that this is being done. Because usually they accuse of delay in care or mismanagement or not being attended by the senior faculty or senior consultant. But when you let them know that, okay, we have called the neurologist and we have called the surgeon and this is what is being done. So they get an idea, okay, not enough is being done. Dr. Asha has written, make sure all the treatment given is documented properly before breaking the value. Absolutely. I think there is no substitute to writing. Documenting is probably the only, savior later on. So make sure whatever you do, you document, whatever you communicate, you document, whatever they say, even that you document, so that there is an evidence to whatever, happens between you and the patient party. Yes, explain in stages, especially if you're going to break a bad news, something that's going to shock the patient and family, you would always stagger it and make sure that they becomes, receptive. We can convert a convenient room or in chamber. Dr. Harimon, I didn't get this point. If you could just heavy chairs are more dangerous.
I don't know. if you don't have a proper, any small room which is enclosed and private can be converted as a counseling room. Abroad, of course, we have a special room for that. Here we may not have, but we can use any room which is private, or you can use your own consulting room as a place where you can talk to them also.
And wherever possible, you should have separate counseling room, under CCTV, so that, and you can inform them, and like they should know that we have a system. There's nothing to hide about it. So, okay, so it's about lifting the chair and how heavy it is. I understand. Yes, we normally think they will not be able to lift, but then you never know out of anger what people do. I completely, understand your concern. So the idea is make it as safe as possible, and make arrangements for the postmortem if necessary, or to take the body home. But again, the whole thought of having the postmortem done, it at times, upsets the family. If they have already had one, this thing, a postmortem comes as a shock to them. So that also has to be talked very carefully, and you have to explain why it is. Yes, Dr. Lata, you have raised your hand. I think you wish to make a point. Please go ahead.
One more thing, what we usually do is after the death, there will be formalities also, the death certificate details. So usually tell my staff that we have to be maximum supportive to them, and we should not make them go here and there to pay bills and all that. I arrange somebody to be there with them, so that it doesn't irritates them more, like other formalities of paying bill or doing all other things. Some person, usually we ask them, somebody to just accompany them. So that is, I just wanted to add.
Yeah, I think that's a very good point, that if death has already occurred and the family has been informed, the post-death, a lot of things, formalities need to be, completed. If we can facilitate them and ease them out, they feel that at least we are considerate and compassionate on that front. I completely agree with you. So Dr. Nambiar has written, whatever is mentioned here is applicable to chronic cases, but it is not possible in cases like what happens in obstetric cases. Dr. Nambiar, I completely agree with you, and that is where I want to bring in the importance of building rapport and creating familiarity with your patient, and giving that impression and message that we are responsible people and we are looking after you with great care. I think I did share one incident with you where a schizophrenic mother delivered a child. Did I discuss that case with you? Have we discussed this case? No. So yeah. So I remember I was taking a session for a group of gynecologists. So one of the senior residents, she shared her experience. It is a government hospital that I'm talking about. So she said in her hospital they delivered a schizophrenic mother, who was full term and in labor pain. They allowed the husband of this patient to be with the lady in the labor room. So throughout her labor, he was there. And as a result, she had developed rapport with her husband. This doctor had developed rapport with her husband, and they were quite familiar and comfortable with each other. After the delivery, like she delivered a male healthy child. After the delivery, the lady was moved to the ward, and the husband was asked to, wait outside, and there was a lady attendant allowed with this patient. Incidentally, at night, this lady took medicine, and also, after taking medicine, she breastfed the child and she went off to sleep. In the middle of night, either it was the attendant or the patient herself who realized that the child was not responding and had turned blue. So, and incidentally, the same resident was on duty. So she was immediately called in. She said, I came in, I saw the child was not responding. She picked up the child and she rushed to the meeting to try to resuscitate the child. And they, unfortunately, they could not save the child. So she said, this gentleman who was so nice and well-behaved when he was in the labor room with her, with his wife, suddenly became completely insane, uncontrollable. He started hitting people, he started breaking things, he started abusing everybody. She said only one person with whom he did not misbehave or he did not, use any abusive language or did not hit, she said it was me. Because while they stay in the labor room, they had become familiar. And he had this feeling that this doctor is very nice, caring, compassionate. So your point is very right, Namia sir, that in gynae ops, we know it's a very unpredictable branch of medicine. All the more important that the family one should know that everything is being done meticulously. And if you have good rapport and that kind of a impression on the patient family, that you would not neglect the patient or you would not make an error willfully. That is what is going to save you. The other case which I shared with you about amniotic fluid embolism, I remember I shared it with you. The words that came from the doctor's, doctor's side. It may not be the doctor herself, but it could be the staff who said, "Please come and collect the dead fetus. We have cats and rats in the system, and they can be, damaged to the dead fetus." So when you make such statements, you can well imagine what can be the outcome. Yes, Dr. Harimohan has written, bereavement is post-death support. I agree. And Dr. Asha has written, most problematic is when the death is unexpected, even for the treating doctor, and no preparation for it. I completely agree. And that is what I'm repeatedly saying, that if you have good rapport with your patient party, that can be, a savior for us. I think wonderful thoughts that you have shared with me. There are a couple of more questions that I want to put across. And these questions are basically to help us understand, are we doing everything that we need to do when it comes to breaking our bad news? So I wish to ask you another question. How do you balance between being honest and then also, being sensitive to their well-being? So before you answer that, Dr. Rajalakshmi has asked a very good question. So in emergency, what happened? So I told you that I spoke to one of the, casualty medical officer of AIMS. And I asked him that I'm sure you must be facing a lot of violence in your setup and against you also. He said, when there's a team who is working on the patient, I would always invariably go and talk to the family and kind of, build rapport and also prepare them, for whatever is being done and what is expected. So making the family wait for a lot of time and not updating them would actually create more confusion, because not that they would stay quiet and be thoughtless, they would actually have assumptions. And when they get to hear that patient is no more, they would believe their assumptions that nothing has been done, or patient has been mismanaged, or people have not done enough. So somebody going and talking to the family, building rapport, creating familiarity, asking their concern, and also telling them what is being done and what normally happens in such cases, kind of prepares them. So all the more important that in emergency, one should make an effort to connect with the family. I think I would really, recommend something like this. Yes, Dr. Manor, you have raised your point. Go ahead, please.
Just with regards to the point regarding postmortem, it's often very contentious issue. So the reaction is the patient is anyway dead. Why do you want to further violate the patient? So I had recently a person who was admitted for alcohol dependence, and on the next day morning he was unresponsive. Probably had an MI, who died. And then so we were discussing, and the family was not very happy with regards to the postmortem. So, and they had different assumptions. One of the assumptions, and the popular assumption, is postmortem is done in suspicious death. So one of their assumption was whether they were suspicious of the fact that the family had done something to the patient overnight. The other thing is that another person came up with the point, someone known to me was brought dead to the hospital. So my point was that, you see, we have not determined the cause of it. So the hospital people there had not done postmortem. So why are they insisting on? So that also happens. So I had to sit and patient explain the process, and it's not just about death, because for things, certificates, other insurance purpose, it's very important to document and find the cause of death. But it's often a very contentious issue, and there are a lot of assumptions with regards to the fact that why we do ask for postmortem.
I completely agree. And I think this is where, transparency and honesty would come into play. Second, their assumptions have to be kind of clarified. If you provide them information why we need to do and how these assumptions could be true or false, and we need to find answers to them, that will help the family also, create peace with the outcome. Because a lot of time, I don't want to discuss that case, but that case that was put by one of you in the group, which was discussed uh, after death, and I think almost after 5 years after death, the family filed a case. This case was put up by one of you in the group. That lake, what was it? Lakeshore?
Lakeshore.
Lakeshore. So see, if they don't know what exactly happened and if things have not been settled, you never know. After so many years, somebody could even, come out with a doubt that probably some mismanagement happened or something, done with malified intention. But yes, if you can handle these questions and help them see the benefit in getting the postmortem, I'm sure you will be able to, make them agree. And plus, we also have to kind of communicate that this is one of the requirements. That's one of the legal requirements. You cannot do away with it. But yes, I understand completely. You require a lot of maturity in handling that situation. Absolutely. Yes, Dr. Vasudevan, I think you wish to.
Actually, it is not our responsibility to ask for a postmortem. Our responsibility is to inform the police regarding if there is an unnatural death, and it is the police to decide whether a postmortem is required. We can insist for a postmortem in cases where we have a doubt regarding the cause of death. Suppose we've been treating, suppose a maternal death, and we think that it is amniotic fluid embolism, and we are sure that it's an amniotic fluid embolism. Even if they don't think, we should insist, because in the court of law, when it comes, if it can be proved it's an amniotic fluid embolism, it goes in our favor. One. Number two, in some instances, the police and the patient's relatives will not agree for a postmortem. In that case, what we have to do is to get a written document, get it written by them that they were not willing for a postmortem. In that case, what happens when it comes to the court of law, we can always prove that because of case of amniotic fluid embolism, we wanted to do a postmortem, but the patients were not. So actually, the decision making of who should do whether a postmortem is to be done is the responsibility of the police. If we take it on ourselves, what happens is sometimes many relatives don't want a postmortem to be done, and when we start telling that you have to do or you don't have to do, they think it is the police who has to take the decision. We can leave it to the police. Our duty is just to inform the police of unnatural death.
I think that's a very good input. That we can always say that it's not us who want it, but it is the requirement by the police. I agree. So, so are there any communication tools that are using when it comes to discussing the prognosis or treatment option? Are you using any tool, any communication tool that you have learned, or you have read, or you are using? Anybody? So, any formal training for any one of you?
Pikes model.
Dr. Hari Mohan for that. So maybe is it? Can you give a brief about it, Dr. Hari Mohan? Yeah, spikes and 6 steps protocol. I agree.
Sorry, this time my online problem is there. That's why. I had done a fellowship in palliative care. So we had a lot of focus on this particular breaking bad news. We did a lot of role plays also. So
that's one branch of medicine where counseling and patient communication is taken very seriously.
Yeah. So what I learned then was we have to put it in steps and pieces. That's one thing. And we need to accept the reactions that are expected. Like, for example, if you tell a diagnosis of malignancy itself, there is initially there is denial, and any bad news. Even if you tell a child is a special child and child is going to have autism, anything, there will be denial will be there. And that denial, we'll have to face that and go through it and explain very clearly, at the same time, not make them more furious or angry. And
yeah, that's a normal, mental process, cognitive process, where people deny or they become angry and they react. We'll talk about it, I think that, but thank you for bringing that up. So if I may ask another question, how do you ensure that the patient or the family has fully understood the information? How do you check or ensure? Anybody? I want somebody who's not doing any talking so that you share your thoughts about it. Dr. Rafi, Dr. Tanzil also, please. Yeah, Dr. Deepa, go ahead, please. Yeah.
And we can ask them about they know about the present situation, and we can clarify their doubts and regularly updating the patient.
So once you have broken the news, a lot of time, you have explained everything, and their last statement would be, I hope patient will survive. So that's
yellow.
So a lot of time, they are just not able to understand or believe, or like Dr. Hariman said, denial. So selective listening, selective attention, that comes into play, and then they don't come sometimes, realize they don't accept also what is. So you have to actually check very clearly. So any tool anybody is using?
Spikes protocol.
Spikes protocol, okay. So I think one of the tools which we normally recommend in every discussion that you have with the patient, it's called teach back. So after you teach back. After you have explained everything, so when you ask, have you understood whatever we have discussed? Patient or the family will always say, yes, I've understood. So you ask them, what have you understood? Can you explain me in your words?
Explain in return.
Please explain me in your words. So the moment you say this, when whatever they say, from that you can get an idea how much of it have they actually understood. So it's very important to make sure that they have understood, and you need to really check it. I mean, asking them clearly, telling their words, it's very important. So what are the common mistakes that we make while doing the breaking of bad news? Either you have done when you were early on in your career, or you have witnessed people doing it, people working under you, with you. What are the common mistakes that you noticed?
Calling the wrong bystanders.
Sorry?
Calling the wrong bystanders.
Okay, calling the wrong bystanders.
Because you call for, say, bystanders of Ramya, then some other Ramya's bystanders will come and they will hear everything and they will nod their head and finally they will go. Then finally, when we ask them, it will be some other patient.
Oh, I think that's something I never expected, but I'm glad not that. That means something.
Yeah, it happens. Yeah, even we might have done the right thing, but the bystanders, out of their anxiousness and anxiety and the tension, they will come and hear everything like this. Also, then.
To prevent that, what we usually do is like if we know the bystander attenders, if you want to convey something, it's like usually that will be asked from the patient itself. It's not after the death or anything. Like if anything, like when we go after and speak in the post anesthesia room, so that's what we'll ask the bystander and we'll call the bystander's name.
Giving all information. Giving lots of information at one single go.
No, we can have who will be the main bystander. Like to whom will be
Primary
the
caretaker. Primary
uh,
care.
primary and
very-
secondary, one or two.
Yeah. Yeah.
Because everything we might have explained to the person who will be there at that moment. And after some time, some other patient, some of the bystander will come and ask. So I tell, see, I have explained everything to Mrs. Shoni. Then he says, no, I am the husband. I came now only. Then so I told, then asked what she has told you. She will say, then I'll ask her to say or tell again, like teach back what all I have told you. Then she will say something which I'm not told. So is that what I meant? Then I will explain to them again. So these sort of things will happen.
So that means knowing the primary caretaker and knowing by name, by relationship is very important, so that there is no error of that kind. What other kind of errors have you noticed in your practice? Dr. Menon, you were mentioning something.
Talk in a hurry
Giving
and
lots of information at one go.
Lots of information in one go.
Just
Yes.
like Madam slide.
talk in a hurry
Yes.
and leave.
Yes. When we appear to be in hurry, that really upsets the family, that it's such a serious thing for us, and you don't have even time to talk about that in a proper manner. Absolutely. What else have you noticed?
Medical terms which they don't understand.
Jargons.
Medical jargons. Yes.
Jargon.
When you don't use the simple and easily understandable language. And I remember in another program, the attendant was that lady's grandfather. There was nobody, and only the grandfather was outside, and they need to go ahead with LSCS. So they called that man and they said, the child is under stress. And that gentleman hardly understood English. He was from a rural, northern India. He came out and he said, I don't know. In Hindi, he said, Doctor me says, stress. What is that? I don't know. Like in Hindi, he was saying. So a lot of time when you use even simple words like stress, which is a very day-to-day kind of a word, they may not understand, and it can create
Birth asphyxia.
Yeah. What other errors have you seen? Somebody's reports being attached to somebody else's file.
Yeah.
You go and tell that this is your diagnosis, and then you realize, no, this report did not belong to this patient.
I think even if the diagnosis is bad, I think there is a need to focus on what all can be done.
Yeah.
Because otherwise, though we must be honest, the patient and the bystander should not be hopeless after our consultation.
Plan B should be discussed.
So that means shifting the focus to what best can be done and how things can be made, acceptable or better for the patient, for the family. I think that's where our discussion should end. And like you said, don't give everything in one go, especially when you can see the family can overreact. It's better to stagger the news, so that they kind of get time to accept what is happening.
What is better at that moment and what is better later on.
Yeah,
Like
later.
that we can discuss.
Yeah.
What has to be done primarily.
Yeah.
Primary care
And one more thing that I want to bring in here is when we are talking about, say, something like cancer or HIV or any other disease, even like Dr. Raki was talking about retinoblastoma and then the need for, enucleation. So we have to, be hands-on with even the rehabilitation part. Because when you're able to talk that, with great understanding and depth, they get to see that, okay, there is a way forward. But a lot of time our focus is on the medical management and we don't go beyond that. So therefore, their expectation that somebody will talk to us and explain us what can be done and how we are going to do it is not met. And therefore, they feel at a loss of information. They look for information, on Google, or they'll go for second opinion, or some other way they will try. So we really need to have that part of communication at hand. Yes, Dr. Lata, you have raised your hand. Please go ahead.
I just wanted to add, ultimately, even the bystanders, when they bring their elderly parents and all, after a certain age, death is inevitable. So in the end, what they want to feel is that they have done everything for their parent by bringing them to such and such hospitals. So that is one point in which we have to stress, and they should not feel guilty. It's a wrong place I got my parents towards them. So we should communicate in such a way that they'll also have the satisfaction that towards that I could do everything for my parents. So that is just one point I wanted to add.
I agree, and that's very good. So when you appreciate their efforts, when you acknowledge their efforts, their desire to do their service to their parents, they feel satisfied that okay, I have done my duty well, and people are appreciating and acknowledging that, and then the news becomes easy to accept. So when you kind of add this to the situation that he was this age and these were the comorbidities, so you have done your best, but not everything is in our control. So that's why these things happen. So they are relieved of that guilt that we haven't looked after. I think that's a very, very important point. So acknowledging, appreciating the family for the effort they have made is also very important. I completely agree. Any other thought about what we have discussed till now? Okay, I can read an answer by Dr. Raja Lakshmi Vaishnavi will ask, how long will survive? Yes, very important question. How long will the patient survive? So how would you handle that question?
So difficult.
How will you handle?
We can only tell the probability.
So never give a very specified period, because we have seen a lot of time when you say, oh, he has only 6 months, and then you realize the patient has lived for years, and then they not only not that, and one day they would say that you were not in the know of it, and also sometimes if they've taken some other treatment, they would believe that okay, that treatment has helped to stay alive. So it causes a lot of disbelief and also. Yes, Dr. Harimohan, I think you wish to add something to what we are discussing. Go ahead. Yeah.
Yeah, for me, this is the most commonest question I come across. From day one, they keep asking me this. Very fair enough also. So generally, if it is, incidentally, I just want to tell now it's not as bad as oncology is definitely improved. The 5-year survival in 1960 was, I think, 10%. Today it is 60%. That is more than 60% of cancer patients can live more than 5 years.
Yeah.
That means they almost have, many of them live for all, they get a cure.
Yeah.
But of course, we still have a very huge amount of deaths, especially when the cases are earlier, not diagnosed earlier in the advanced stages and all that. So generally, we never give definite dates. We tell it is not going, suppose it's going to be, it's not going to be years, it's going to be months, or it's going to be days. So if they're asking, is it going to be in years? No. So we just tell, let's look for the next birthday or the next anniversary as our target, and let's hope for the best. So generally, they accept that. So it's not going to be years, it's going to be months, or it's going to be days. And let's look for the next target date.
I think that's a good way to answer their question. So one more question that I want to ask here, since we are discussing at length about it. A lot of time when patient says, don't tell my family. Or sometimes patient is an elderly parent and children say, don't tell my parent that he or she is in final stage of cancer. And how would you handle both? Yeah. How would you handle both? HIV, the patient says, don't tell my wife. How would you handle that? Has anybody handled such case?
If the potential threat to the spouse or someone, then we should say, like in case of HIV and hepatitis B and all. Otherwise, we can give consideration to them. That's my opinion.
I think we should ask the reasons why they want and then progress from there.
It's a notifiable disease and it has to be notified to the authorities. That is the most important thing. And to the spouse, definitely, we should be informed.
Absolutely. I think, thank you, Dr. Nasuddin. Yes, yes. Go
And
ahead.
often when we tell it's not just the spouse, and there may is the spouse who's infected and there might have been transmission to children. That is something. So this is often a question that comes in substance use disorders, people with injecting drug use, hepatitis C. So I think they are more okay, because at the end of the day, they should also be comfortable with regards to communicating.
I think good points that have come up, that one, it is very important to notify. It's very important to inform at least the person who can be directly affected. So in HIV, we know the wife or the husband can be affected. And then of course it can be passed on to children. So it's important to, but straight away saying this, that do you want to infect your wife? You are such a irresponsible husband. I'm sure you must be doing that. If you ask, why don't you want to tell? And how is that going to help? And then, do you think she will not get to know when you come for treatment, for medicine, for follow-up? So this is something you will not be able to hide. And if you tell her, then at least she can take all precautions.
I think discussing the complications, I think for the lay people, HIV is something which is associated with stigma and sexual transmission. So, but they're not really aware of the degree of complications. Same is true for hepatitis C. I think once we discuss the complications, and it can be a matter of life or death in that sense, a lot of them are willing.
I agree.
And they're more comfortable.
Yes.
Usually in HIV, we give a pre-test counseling. We explain everything to them before doing the test, and what are the complications about the disease, about if the patient is HIV negative, what will happen, if the patient is HIV positive, what will happen. Everything we explain to the patient. Then nowadays we have to get a written consent, then only we can do an HIV testing. And while revealing the result, it is through counseling we give the result, that is post-test counseling. So anyway, they'll be aware of what all is happening, and then we explain the consequences. We give safe sex practices, counseling about safe sex practices and all. So gradually
the partner is not, in the picture till the diagnosis is made. We are talking about that condition. But once we are very clear with the diagnosis and the partner is still not in know of what is happening, that is where usually they say, don't tell my. I remember there was a case. It was a very known celebrity, and he probably had this, and then he said, don't inform my fiance. And then the doctor, when you have that discretion to communicate to the spouse or to the partner, that was communicated, and that created a lot of news in the news.
But usually they say that don't reveal it to the wife. That's what they say.
Yeah, absolutely. I completely agree. So when children say, don't tell my parents, one of them has cancer, so they say she's too old to take it, so it's better not to tell her. She won't get to know. Let us continue with the treatment, but let's not tell her. So how do you manage that situation?
Can I tell?
They eventually will know what it is.
Yeah. Yes, Dr. Paul, go ahead.
I had a similar case. It's not that like this patient was having CA esophagus. The patient has come for surgery. So he has come for a pre-anesthetic checkup. And this patient has other comorbidities like IHT, CVA and things like that. But he has recovered from the CVA. And these children have not told the seriousness to the patient. So when I was trying to explain, they were trying to show their hands and trying to show me that don't tell. So and the patient was very particular. He was saying, if anything happens to me, please don't operate. If you have any doubt something happened to me, and the bystanders are telling them, don't, you have to go ahead. So I have faced a similar this situation. I don't know how the others will take
How
it.
did you manage? We want to know from you. How did you manage that?
that is see, I failed, literally failed. I feel after the surgery. The patient was okay during surgery. I didn't tell the patient. After 3-4 days, he had a leak, and this patient died. And even now, I remember his face, and sometimes he will come in my sleep. I have expressed this to Dr. Sreekumar when he had come for into Calicut. What should we do? So definitely after that, I always tell the patient, because it was his right to leave or not. So I should have told.
But I'm so glad, Dr. Paul, that you have shared this case with all of us. See, at this stage also, when we request to not reveal, we are confused. How do we really handle that? And sometimes we, kind of bow down to their request and, do what they want. One, of course, you have denied the patient of their right. Patient has the right to decide whether they want to know or not. Patient says that, okay, don't share any information with me and you can share with my family. That's perfectly all right. And that also in writing. Although it's more of a, legally also, but then at this stage where we are discussing, it's more of a moral question than a legal question. Because nobody has legally challenged us for that decision. But definitely, I think how would you handle? I want to ask others. If that was the case you were handling, where the patient family says, don't reveal to the patient, how would you handle that? What
are you asking me or others?
So, Dr. Paul, I'm asking others. I want to ask from others.
It is the right of the patient to know what he is suffering from.
Absolutely.
Whichever the relatives say, you have to inform. I have a very bitter experience with this because we were from my school days. My 3 friends. One is a plastic surgeon professor in Delhi, in one of the medical college. The another one is a gastrosurgeon in Delhi, in one of the famous hospitals in Delhi. The other person is a classmate of mine in school. We were all in school, and his brother was to be operated in Delhi by this gastrosurgeon. So this brother, the classmate who was told us that, told this plastic surgeon and the gastrosurgeon and me not to reveal that his brother has malignancy. But just before this, one day prior to the surgery, the gastrosurgeon told the patient that you are having malignancy and I have to do, this is the procedure I plan to do, everything. Unfortunately, the patient died on the table. This has happened 5 years back. Even today, my classmate doesn't talk to all 3 of us. Whenever we have a get together, he doesn't attend. If we are not there, he attends. He's still not understanding. We have told him many times that this is the situation. We have to reveal. All 3 of us have sat down, discussed with him, but he just refuses to attend any get together when we 3 are there. If one of us is there, he doesn't attend.
Thank you for sharing that. I think you have personally experienced the setback of not telling, and when telling in a manner that upsetted the family. So I would say, rather than just saying that it is patient's right to know and it's my duty to inform the patient, I would again say, talk to the family and help them see the reason why the patient should know, the benefits of letting the patient know. For example, like in this case, the patient died. In your case also, Dr. Paul, the patient died. The thing is, letting the family know that all of us, we keep a lot of things pending. I will do it one day. I will do it one day. I will do before I go. Of course, if I meet with an accident, nobody can be blamed for it. But if I know my death is, near, and if I can do whatever I have on my mind to be done. I think it's a big relief for the parting soul to know, okay, I wanted to make a will, I made a will. I want to apologize somebody for what I did to them, I apologize. I wanted to sort out some things that were not sorted when I was, and in relationship we have seen. I've seen brothers not talking to each other, family members just being, strange and not, sorting out things. And then when you are at the fag end of life, you have a realization, whatever is important, everything is so well with everyone. I think let's sort out and let's, okay with that. So all those things are equally important. Giving that person a chance to do whatever that person wants to do before that person goes. I think when you are able to talk with the family in this manner, maybe it will make them open to the idea that yes, I think we should not deprive the person or the soul of those things. That is one thing. And second, we all know that if the person knows and if the person participates, actually can be, done in a better way. Third is we have a tendency to underestimate the power of an individual to accept the reality. Most of us are more powerful than what we assume. Plus, if you are talking about elderly parents, they have seen life, they have seen death, they have seen, things in their life, so they have an idea. Plus, in case you will take them for chemotherapy or radiotherapy or even for surgery, they ultimately have a realization that it is something serious. And for them, serious, they would know that it's most likely it's cancer.
Yes.
So this is how when you are able to, talk to the family, I think this can help us. What do everybody say?
Yes.
In my case, actually, they were worried that if I tell them, the patient will have some issues beforehand itself, before the surgery.
So that's what I'm telling, that we have a tendency to underestimate the human power to accept things, but actually we are much more stronger than what we assume. Yes, Dr. Asha, I think you wish to make a point. Go ahead, please.
Yes, continuing on lines of what ma'am said, we underestimate their self-efficacy. Most of them can stand it. So I don't know if it is right, but sometimes what I use is many malignancy news is what in ENT we have to give. Many of them say, don't say to the concerned patient, young lady or whatever, don't. So what I usually do is I tell the family first, the patient is not brought when the results are in. So I tell them, you try to break the news to them at home in a peaceful atmosphere instead of me first. And the next visit, when you come with the patient so that I can talk about the details. So if you don't want me breaking news there, you can do it in your family. But you can't proceed with treatment without the patient knowing it. That's what the usual stand I take. I don't know if it's right or wrong. That's what I take usually.
I completely agree. So I think thank you for the wonderful discussion. You won't believe that we have spent 1.5 hours discussing breaking bad news. It's been a great learning experience for me also, because all of you are already doing it. And I think sharing this information, this experience with each other, I'm sure it would help each one of us in dealing with this situation. So I wouldn't be doing the role play because I think all of you are already, thorough with it. But I would like to share the presentation with you so that you are able to capture some of the points that maybe if we have missed in the discussion, we will have it. And then a short protocol. Again, these protocols are just like guidelines. They help us design our communication. There's no fixed line about it, but that definitely helps us to understand how we can go about and what are the lapses we are likely to make. Any questions or any point from the audience? Okay, so I let me share the screen with all of you. So I think one clarity that I wish to make, we normally think bad news is something very serious. Honestly, I have seen people, mothers literally fainting when they get to know that their child is, either myopic or child has high myopia. So it's not just disease, very serious, disease or uh, a very major illness, but it could be as simple as, myopia, which can upset the parents. But we all know that anything that is serious and adverse event, which has direct impact on the individual's life or future, and indirect bearing on the family and society, that is definitely. Dr. Rakhi, I think your device is on unmute mode. If you could mute your device. Yeah. So,
Madam, 1 second. Sorry for interruption. What is the third part you had written in that family?
Indirect bearing on the family and society. So, for example, it's not just the patient, but also the family and society is affected by them. Like, for example, HIV case, if you're talking about.
Okay.
Yeah. Or Alzheimer's for that matter, Parkinson's for that matter. We know the family is going to be definitely affected with this because it's not just the patient who will be managing, but the family on the whole will have to manage the situation. So it's a bad news for not just the patient, but also for the family as well. So these questions you have answered, and I think we had a huge discussion around this. They were really very pertinent questions on my mind, but we had a very detailed discussion on these points. So I'm not going further. So we could have done this role play, but I think the kind of discussion we have had has given enough insight into how one should be handling or how you all are already handling. So what challenges do you think one normally experiences when it comes to breaking up bad news? Like you shared, there's a concern at the back of the mind. How will the family react? How will they accept it? Will they blame me for the outcome? How about the patient's or family's perspective? What do they value? What do they want?
What best treatment?
So definitely they want to know what are the options available and what can be done. So a lot of studies have shown that patients value doctors who communicated clearly and empathetically and provided thorough explanation and involved them in decision making. So it's not like just you announce the diagnosis and you tell them what is the option, or in case if you're not going to deal with it and you just refer them to higher center. But I think they want to understand what it is and what needs to be done, what are the options available, what is the best option for them. So they want somebody to talk to them and explain to them. I remember my brother-in-law. So he had cyst in his brain. So when they went to surgeon, the surgeon said it needs to be operated. When they went to neurologist, he said nothing doing with medicines, it can be cured, and there's no need also for the medicine. It's harmless. It's not going to so there's no clarity. And I'm sure in even cardio, we all know if you go with a block to a cardiologist, they will say, okay, let's go ahead with stent, 1, 2, or 3. If you go to a surgeon, they would say that, we need to operate, and then with surgery, we can give you a better result, or that's the only option. Again, patient is confused whom to trust and whom not to trust. So these are the, things patient really are confused about. So when it comes to gaps in what patients want and what they receive, studies suggest that almost 50 to 60% of patients want to discuss life expectancy. I think that's one of the commonest questions you will get to hear. Dr. Harimohan will definitely, agree with me that every patient wants to know how much time I have. Whereas most of us are not very comfortable talking about it, and we end up, giving them not very, satisfactory answer. When it comes to, discussing the effect of cancer or any serious illness on the patient, Patients want to talk about it. How is that affecting their life? How is that affecting their relationship? How is that affecting their work or day-to-day activities? But we at times become so focused on the disease and the treatment that we are not very comfortable talking about the effect of these diseases on their lives and other aspects. So this one, slide I received from a source. They're carrying a dead body and they are carrying a banner in front of that dead body, which says that this patient died because of the error of this patient, the negligence of this doctor. So I'm not sure if actually any error happened, but I'm sure definitely there must have been some communication failure, because breaking of bad news is one of the trickiest communication and most difficult one. And because we are going to talk about life, death, poor prognosis, complication, and unexpected outcome, and it's actually not easy. We all know that most of the aggressive reactions occur after the breaking of bad news. So that's an indication that one has to be really good at words, really, aware of how to handle emotions. Especially younger generation doctors experience more challenge because they are probably still learning how to handle emotions, how to control their reaction to the situation, or how to handle even difficult questions coming from the patient party. So breaking up bad news actually require advanced level of communication skills and great experience in handling emotion. One really needs to be good at words, handling emotions and questions that the patient party is going to come up with. And then how do you control yourself and not react instantly to something that is not acceptable or not bearable. So a word of advice that I would always give to everyone who handles patient: please build good rapport with every patient, because you never know which case might turn into an eventuality and have an unanticipated outcome. So having a good rapport with the patient party, creating familiarity with the family and the patient is a very good way to mm, to have good rapport with the patient. So regularly update the family and the patient, address their concern. It could be financial concern, it could be for second opinion, it could be about outcome, it could be about whatever their concerns are. These should be addressed whenever you have a interaction with the patient or the family, and then involve them in decision making. So a lot of time when you take a decision on their behalf, thinking that this is the best option that they should go for, tomorrow they may back out and say that we never wanted to do this, and because you said that go ahead with this surgery, so we agreed for the surgery, and now we have ended up into something like this. So giving them the chance to decide by providing them all the information that one requires to take an informed decision, I think that would help us in kind of being sure that it is not I who have taken the decision, but it is the family who has taken the decision, but you have just facilitated, and then the outcome doesn't become your responsibility completely. Of course, transparency and honesty throughout the diagnosis and treatment and management is very important. That is what helps to satisfy the family that nothing wrong has been done by us, or we haven't lapsed anywhere in our care. So that is something we have to be very very careful about. And one more thing that I wish to emphasize here is, whenever the patient is in critical condition or has some serious diagnosis, it is the family actually who is looming under the greatest fear. And the greatest fear is fear of death. We all know that fear of death can actually change anybody's behavior, anybody's thought process. So studies have shown that many of us look after the patient very well, but when it comes to looking after the family's concern, we think they are not the beneficiary of our care, and therefore we don't really address their concerns. But it's very important to understand, I would say, patient is far more comfortable than the family, because patient has a bed, patient is getting nursing care, medical attention, and everything that is possible. It is the family usually you will see will be suffering and running from pillar to post, arranging things, arranging funds, looking after family, on the other side. And then we all know not many hospitals have, proper facilities for even attendants. So a lot of time we see them sitting outside in corridor, I mean, lying down on floor with the sheet on the ground, and there's no place to rest or sleep or food or even there, to get refreshed. So, I mean, that is something that we have to be cognizant of, and that's why their emotions and their exhaustion with this situation is very much understandable. So whenever the patient is critical or you're going to update the family or break the bad news, it should always be done by the senior most person. The person who is handling the case, the person who knows the case. A lot of time, the responsibility of sharing is left on the junior doctors. That also upsets the family. And they feel bad that we haven't, the senior doctor hasn't come and spoken to us. So I'm going to share this protocol with you, and I'm sure you know other protocols also. So these are just guidelines to help us how to, make sure that we do things in a proper manner. So this is 4 P's, where is the preparation of physician, place, and patient. Then second P is about performance. How do you go about doing it? Third P is palliate, and fourth P is planning with the patients. So when it comes to preparation of the physician, as many of you have very rightly said, know and confirm the facts thoroughly, know every finer detail of the patient's case, what test has been done, what are the results, what is the plan of action, or what you think, how you have reached to this conclusion. You really need to be well aware of that. Before you actually break the bad news, it's a good idea to make connection with the patient and family. So even simple questions like, how's your pain now, or how's your fever now? Could you eat well today? Did you sleep well? So that's how they become, they feel that, okay, you're not going to immediately tell something, but you're kind of building a connection with them. Be mentally ready to spend some time, because patient and the family may have a lot of questions to ask you. Anytime if we appear to be in hurry, that can upset them, that can give them a feeling that, we are not affected by the seriousness of their condition. So manage interruptions like phone calls and visitors. Sometimes, you have somebody waiting outside and you say, okay, let me finish this and I'm coming out. That really upsets the family, and that can, further outline that we are not serious about their condition. I have re-emphasized that please do not delegate it. If it's your case, you have handled it, make sure that you do the breaking of bad news and you talk to the family. As I said earlier also, it's always a good idea to sit down at a separate place to ensure their privacy and also comfort, where you can, talk one-on-one with the patient or their family. Having bystanders or others around you can change your behavior also. We also get upset that somebody is overhearing my conversation and the patient or the family is shouting at me or finding fault with me or is doubting my integrity or my capability. So the presence of third person can aggravate the situation and alter our behavior. So it's always a good idea to sit and talk to them. So in case if they say something which may not be true, but you may still accept, thinking that, okay, let the family vent out. But if you do it, outside OT, outside labor room, outside ICU, people who are overhearing, they might interfere also, and then you also become conscious. So involving, people like your colleagues, if you think you want to have somebody around you, or a social worker or a senior nurse, or even patient's family member who you think understand your point of view and who agree that yes, you have done your best and you haven't failed in your duty. Having them around will help you in handling situation and controlling emotional reaction. So things like facial tissue, glass of water, if you have it with you, it kind of communicates that you understand that there can be, and somebody can get upset, and glass of water, when you offer, it shows your human side. Before you actually say anything, it's very important to assess patient's starting point. So that means how much they know. For example, if the patient has come from another hospital, has been referred by somebody, so that means patient has an idea that I have been referred by a doctor, private practitioner or a smaller setup, and they have referred the patient to a bigger setup. So they know that, okay, something has been already shared. Asking directly also is not a bad idea, that what has your referring doctor told you, or what do you think it is like, or why do you think we did this test? That will give you some idea how much they already know. It's not a bad idea to ask how much they want to know. Although this is not a very regular practice in Indian medical system, to ask the patient, what do you want to know? Normally we would go and do the talking, but we have seen a lot of time patients who are very scared or who are more anxious, they would straight away say, doctor, don't tell me anything, please tell my family. Or they may say, I'm not interested in knowing what it is. I just need treatment. You go ahead with treatment. Don't give me all the details. But there's no harm asking how much does the patient want to know, because a lot of time, they honestly do not want to know. So also check patient's readiness to receive, because sometimes if they're unprepared, they can, overreact to the situation, or they may actually, faint or something of that sort can happen. So if you think they are not prepared, or they may react to the situation in an anxious manner, so we can reschedule, or we can actually stagger the news and kind of prepare them for what we are going to pray. And then also it's a good idea to ask them whom all the patient wants to engage in discussion. So we normally assume whoever is there in the room with the patient, they are probably family members and the patient is comfortable talking in their presence, especially if it is a room setup where there's a patient on the bed and there are relatives around. But you never know, maybe the patient is not interested in talking in front of them. It's a good idea to ask them who are they, and if you think they're not very closely related, we can reschedule, or we can postpone till the patient is free. And a lot of time we have seen sometimes when there's a conflict between husband and wife, or the girl party and the boys party, at times they don't want to share the information. So it's good to first confirm whom all they want to engage in the discussion. So if you go by studies, what is the patient's information need? Almost all of them want to know what their diagnosis is. I don't know if you have ever come across any patient where the patient said that I don't want to know about my diagnosis. That's very unlikely. So most of the patients want to know what it is, and they also want to know as much as possible, because then they can plan or think how they want to really manage the situation. So a lot of time when you start discussing with them, you will get to see there can be illness denial, there can be wishful thinking, or there can be unrealistic expectations. In case anytime you notice something like this while discussing with them, I think it's very important to address all this appropriately. For example, if they have come to a tertiary care hospital and they have this expectation, no, I know you have all the machinery, you have all the doctors, they have all the setup. They assume automatically that since we are in a bigger setup, we will recover, or the patient will recover. Or when they are spending a lot of money on the patient's treatment, so somehow they have this expectation where they think money is equivalent to the possibility of recovery. So they may equate these two things. So we have to, if anytime you see something like this, it's important to help them know that maybe if the quality of care or the options available could increase with the money available, but then that is not the deciding factor for the outcome. So address those things appropriately by talking to them, explaining to them. In case if there's any misinformation, it's important to correct it then and there itself, so that tomorrow they don't blame you that I told you last time also and that time you did not say that this is not like this. So correcting that misinformation is very important. And then if you think that they may not accept immediately, tailor the bad news so that they get prepared for it. When the family says, please don't tell the patient, we have discussed this, I think I will not discuss at length, but then let's remember that we are legally and ethically obligated to get this request from the patient. If the patient says that don't share this with me, talk to my family, then it's a different thing. And that also in writing and getting it signed by the patient, so that you have an evidence that this was, the decision of the patient. But when the family says, I think as we discussed earlier also, if you ask them why they don't want to share and what are their concerns and discuss them the benefit of disclosure, most of them will, come around. They will understand why it is important to let the patient know, whatever it is. When you are performing, when you are announcing, when you are talking about their condition, it's very important to be sensitive, but at the same time, you need to be straightforward. So any attempt to minimize this severity actually can create vagueness and confusion. So you will have to actually be very honest, but of course, you have to divulge all the information with great sensitivity so that it doesn't come as a shock. So avoid precise answers, always give range so that they like Dr. Hariman said, so maybe we can look for the next anniversary date or for the birthday. So that gives them an idea that how much time they may have. Don't take away all hope because as we have discussed this at length, that they may feel hopeless. So it's good to actually be ready with these things on your mind. Because if you know how you have to handle it, you would leave them with some hope and some hope that I would recover and I would become better. Yeah. I can see some answers. Most patients want to know. Many family members don't want patients to know that sickness. Yeah, yeah. This is what I think you have shared. Thank you. So, when it comes to performance, as I said, use simple language, as simple as possible. Avoid all technical jargon because if you use jargon, they may not understand, but they will never say that I don't understand. And also avoid single steady monologue. Make sure that you allow them to speak, you make them talk, you make them share what they think or feel. Because if you do it as a monologue, you may think I've shared all the information. But how have they received? How is it impacting them? How are they agreeing with it? Are they okay with it? Are they inside blaming you for the outcome? That you will only get to know when you will make them speak and allow them to talk. So try to pause frequently in between to let them absorb the information, and also in case if they wish to ask something, that will give them a chance to speak when you pause in between. So every time you see that they are, emotionally upset or they are not able to cope up or they are taking time to absorb, I think using silence and appropriate body language is a wonderful way to communicate that I understand that it's very overwhelming and you are with them in that situation. Like Dr. Harimon said, a lot of time they start crying and you just be quiet and you give them that opportunity to express themselves. That shows your human side, and that's what they expect from us. That if they are crying, we would not be upset about it, or we will not be in a hurry to say everything that we wish to say immediately. And then make sure that you check for understanding. As I said, a lot of time you have said everything, but they still haven't understood. And then in the end, they'll have this question: will he recover? Can this be treated fully? This we have discussed in a number of discussions. Your body language, your tone of voice has more impact than your words. Honestly, when you break the bad news, they are in cognitive deficit. They are hardly able to hear much or understand much. But yes, your body language, your tone of voice is communicating how you are delivering that news. So it's very important to make sure that you have an appropriate body language, and you that kind of communicates your human side. So whenever you start interaction with them, greet softly, establish eye contact. I think that's very important. A lot of time when you don't establish eye contact, they might doubt that probably either you're hiding something or you're not sure of it, or probably you are responsible for the outcome. So very important is to make eye contact and communicate that I haven't done anything, but I'm here to share this. I can see 2-3 answers in the chat box, comments in the chat box. So Dr. Harimon has written, in India it's flexible, abroad we better do. Yes, that's what I'm saying. In India it's very different, but then you never know. Sometimes if you have a relative who's from abroad, he or she would definitely try to kind of bring in that culture here. And there it will be difficult for you to explain that in India that's the reality or that's how the things work. So there they might, insist, or they may blame you for not following the protocol. Dr. Rajalakshmi has written, very old, 90 or plus, should we still disclose? Again, after you have explained the family and they don't agree, I would say we can respect their decision. We can respect their feeling. I remember in one of the programs, one of the participants, she shared that my grandmother, who was who had stage 4 cancer, and all of a sudden it was diagnosed. Otherwise, she was hale and hearty and very active, but she was almost like 90 years. So we didn't want to send her with that. She did not. She said doctors did try to convince us that you must share, but then we did not. So I would say, at that point, there's no harm respecting their decision, because the whole idea is to at least try from your side, explaining them that why the patient should know. But if they feel the patient is, 90 plus and is relaxed, enjoying life and is okay and has done all his or her responsibility, maybe you can take a chance. Okay, yeah. So avoid labels like cancer if they're not very keen on its origins. Yes, I agree. We don't use the word cancer and we use some other word and they're okay with that. There's some growth or something like this that we can say. So when we're talking about the body language, I think maintaining open posture, where you indicate that you are trying to connect with them, you lean forward. Your tone of voice plays a big role. As I said, whenever you would break a news like this, it would actually come as a shock, and it leads to cognitive deficit. The person completely sometimes becomes disoriented with the things around. So their tone of voice and your body language is, more noticeable than your words. So a lot of time patient would start saying something, they'll start babbling something, allow them to express. It could be something actually very irrelevant to what you are talking. But if you allow them to express and listen attentively and kind of give them a chance to vent out, it gives them, time and space to kind of accept what it is. So sometimes the emotional reactions that the patient party might give might appear very aggressive, but if you don't react to it, a lot of time they start calming down after they have expressed their emotional reaction. But again, you need to choose how safe or unsafe you feel in that situation. So comforting the patient or the family with appropriate verbal and non-verbal gesture is a good way. So sometimes when we touch on the hand or on the shoulder or on the head, again, you need to see whether that is appropriate. Sometimes they would really, throw away your hand, push your hand away, and kind of refuse to take that comfort. So you have to evaluate whether this is doable or not doable. So these are a couple of examples that can help us to start the conversation, where you are not straight away going and saying that this is the news that I want to tell you. But when you start like this, I'm sorry, I have to tell that the report is not okay, or unfortunately, the report is not very encouraging. So that again kind of, shows your human side. How do you normally start, if I may ask you? Do you ever use something like this, or any other way? How do you start? Okay, Dr. Haribon has written, I asked them to recount what they know. Okay, that's also a good way. How do others start?
So you suspect a growth or suspect
Hmm.
something untoward. So we'll have to do some investigations and then.
But after investigation, if it is confirmed, and then you need to kind of announce.
I think both. We just recount with what symptoms they have come with and what are the investigations that we have done so far. And then we say that we have now got the results. And that may not be good news.
Yeah. So that means we have to at least start from one point and then, build on it and then ultimately break the news with them. So how does the bad news hit patients? It actually leads to cognitive, behavioral, or emotional deficit. The person suddenly become, completely quiet or confused or not able to, react in a manner. We can't change the news, but we can definitely, help them have realistic hopes or make it worse by giving a cold behavior. So when you give cold behavior to these reactions, they kind of, feel confused. So studies suggest that almost 50% of the patients would respond with shock. 46% would report being frightened, and a lot of them actually report sadness. And again, a good number of them would accept, in a while. And then around 15% of them said that they were not affected. So, but we know it's a very mixed kind of a thing. The patient may react by crying or suddenly becoming silent, or they may ask you, "Are you sure?" Or they may doubt that the report is wrong, or they may say, "We want to go for a second opinion. I don't believe this. I think there is something wrong. Either you have done the wrong test or it's not my report." So it could be denial kind of a thing when they're not ready to accept. So the psychological response, I think all of you know, it is DABDA. It is called DABDA, DABDA. That is denial, anger, bargaining, and depression and acceptance. So you will see people initially start with denial, or they may be shocked, they may not accept or believe. Then you would also see anger, aggression, unhappiness. Sometimes they would blame you for the situation. Once they start realizing that this is the reality and this is what the situation is, then they may start bargaining with you, saying that how much ever money you want, I am ready to spend, but please give the best possible report. Or they may ask you to refer the patient to the best possible hospital wherever they have all the facilities and all the amenities. So that's how they bargain with you. And once the reality sets in, they would become quiet and act, more like, settling down. So it will be more like depression. They become silent and sad about this situation. And finally, it is acceptance, where one, accepts and then thinks, now what next? And what do we do from here? How do you deal with this is when you see denial, I think the best would be to provide them with information. When they're not ready to accept it, probably your reports and investigations and whatever you have done to confirm and to be doubly sure, if you share that information, they would believe that you have been very careful in confirming whatever you are saying. If you see them angry, staying calm, listening to them, and not being too reactive is a good way to handle and allow them to vent. Usually, after they have vent, they will realize that if you don't react with anger to them, so the reality starts setting in. That is where they will start bargaining with you, where they'll say that whatever you want, I'm ready to do. How much money you think I need to spend, I'm ready to spend, but please save the patient. So that's where you need to really, help them see the reality and also show that, whatever is needed is being done. And that's the best that can be done. So I think being empathetic in understanding that these are the ways human mind processes any bad or sad news. You would not be too reactive to this, and you will not even be annoyed about it when they say, take as much money as you want, but save my patient. And that's where you can assert also that if it was about money, then rich people would never kind of die. So when you see them, becoming quiet and becoming, sad about it, that is where you need to give them direction, because they would be clueless now. What next? Now what do I do? What needs to be done? So that's probably where we need to give them direction that, okay, I think after this test, I think we need to do a couple of more tests, or these are the options available. And then you take them to the options of treatment. And when you see them accepting, I think that is where, encouraging them would help to kind of make them move forward. So empathy, that we have talked at length in number of other sessions also, is one of the tools that will help you in this situation. If you can be empathetic, if you can see things from their point of view, if you behave where you express empathy by using the right tone of voice, by using right words and the right body language, it will actually help them see that you are with them in their situation. So couple of sentences that can help you to express empathy where you say, I know it's very upsetting. Anybody would be, shocked to hear this. So I understand you're not able to believe that this is their reality. So when you use something like this, they get to kind of feel comforted that, okay, we understand how serious is the situation or how difficult for anybody it would be. Role of nurses, residents, and paramedics, we have discussed at length already. So they need to be more accommodative, more understanding, and less, restrictive and less controlling and less dictating. I think that's what patients expect from us when they know the death is inevitable or the condition is critical. So we need to be more accommodative to the family's needs. Clinician's perspective. So how many of you still experience stress or anxiety when you're going to do it? So I know studies suggest that, most of us would experience some amount of stress and anxiety before and during the breaking of bad news, because we don't know what is going to be the reaction of the patient party. And after you have done it and if everything is okay, then mostly we start becoming, okay with the patient party is accepting. Usually the concern is we are uncomfortable about the patient's expectations, especially if they expected something great and if you have not been able to meet their expectations, we feel uncomfortable that we haven't been able to deliver what the patient expected. Then you are going to destroy patient's hope because till now they were hoping that if everything will be fine, if I take treatment, if I get operated and be fine and I can go back to my normal life. But when you actually tell them that this is the stage and this is the outcome, then there's a possibility that you fear that you're going to destroy their hope. Also, in face of uncontrollable disease, I think anyone would feel, okay, we are not still that evolved to prevent or control the illness. I think COVID has really given us the taste of uncontrollable disease. And then also, those of us who are not prepared to manage patients' anticipated emotional reaction, that is where the major anxiety and stress comes in, because we fear that probably we will not be able to handle. What if the patient hits me? What if the patient starts becoming aggressive and hitting others and breaking things? And then sometimes we feel embarrassed, especially if we have painted a too optimistic picture to the patient. So for example, as I said, I read a tagline, in Delhi, in one of the eye chain, eye care chain that said, come from home, get the surgery done, go to your office. That was their tagline. So when you make such tall claims and when patients have some complications, maybe, a vitreous loss or nucleus drop, that's where it becomes very challenging to, really explain that what has happened in the case. And we all know that no branch of science medicine is risk-free. Even we have seen, patients collapsing with chest dose. So assuming that nothing serious will happen is a very wrong impression we have. And so therefore we need to always be very realistic expectations. Let's accept our professional limitations and also communicate in a very clear manner to the patient. We also have to learn to control emotional reaction because patients are likely to react emotionally. But if we can manage our own emotions and can handle the patient's emotions, I think we can handle it better. Keep the family updated. They will be better prepared for the news. Keep them in loop. Let them see the patient. Let them know what is the likelihood. And then document all communication. So whatever you communicate, document, and whatever you document should be communicated. The common mistakes that we kind of sometimes make is when we avoid to break the bad news as long as possible. Or we just don't do it and we hope that somebody else will do it in our place. Or when we lie, or we are best being economical with truth. So we are not telling the truth, but we are not lying. So it's as good as lying. And then when we deliberately do not take patient's view, we can see the patient is upset or aggressive or is not believing or is in shock, but we just do everything in a very, very monotonous manner. And then also doing the activity in a mechanical manner. These are some of the mistakes you would see happening. Once you break the bad news, the patient and the family fears that you're going to abandon them, you're going to leave them. It's very important to actually reassure them that they are not going to be left or abandoned. Establish a treatment plan, whatever their current symptoms are, they need to be treated. Discuss what next needs to be done, what are the options available, and what would work for the patient. Establish a time for follow-up or appointment. And also, in case if you need to, send them to another place, arrange for appropriate referral, give contact details, if possible, talk to the person there so that these patients feel properly, handed over to the next doctor. And then having people like family, friends, social workers, spiritual counselors, it's a good idea because a lot of times they are good at providing emotional support, which sometimes we find difficult to offer. So if you can involve and engage them, that will actually unburden you of the responsibility of providing all that. So to summarize, I think most patients want to know, and if done rightly, it actually improves doctor-patient relationship. So if you are able to do the breaking of bad news in the right manner and tell them the information that they need, they usually are happy and satisfied, and they are thankful to the doctor for being, more open about it. It helps patient and the family cope up, and it also fosters a collaborative relationship where you become, you kind of navigate them, and they are, ready to follow your guidelines. This can also prevent aggressive reactions because then they feel that you are with them in the situation. Like Dr. Harimon has written in his message that I add that we could do our best as a team, family, us and you. So that means you partner with them, you show them that you are with them in that. So these things actually, comfort the patient and the family for, kind of being with them in the picture. So the 6 steps of breaking bad news that we have discussed just now is prepare yourself, prepare the patient, prepare the place where you're going to do it. Find out what the patient knows, find out what the patient wants to know, share the information, respond to the emotions. I have underlined this because I want to emphasize that we need to learn to handle emotions. If we can manage this, I think we can handle this very well. And then plan and follow up with the patient. Disease and death, how it can impact anybody, I think we can only understand when we have personally experienced something like this. So when we are with the patient in hospital as a patient attendant, or we are a patient ourselves, or we are, personally affected by a situation, that's where I think we get to realize the patient's plight and the family's plight. Of course, I don't wish anything of that sort for anybody, but I personally feel that we become more, understanding, more humane, more considerate with the patient and the family. So this is in a nutshell about breaking up bad news. Any questions? I know we have gone a long way. It's almost like going to be 10 o'clock.
Madam, about the question which was asked about 90 years, should we tell or not?
So as I said,
I just wanted to add something like if the patient is demanding, then yes, there is no need to, but otherwise you should definitely say, being a child of a 98 and 94-year-old parents, I feel so.
Could you repeat? I could not get the
No,
last
regarding the like
question
somebody
that
asked about the above 90, like
Yeah.
if the patient is dementing, yes, you don't have to tell him.
Yeah.
Otherwise, or tell him or her. Otherwise, you should always tell. That is what I was telling. Then I said, I being the son of a 98-year-old father and 93-year-old mother.
But I still somehow feel if the family feels that we want to, bid goodbye to the person, without making the person feel bad, because we know the knowledge that I have cancer, not everybody reacts in the same way. So this lady who had undergone, treatment, and she was doing very well. I mean, there was no relapse, no problem. So she had gone for her routine checkup, like annual checkup, where she needed to screen for the metastasis. The day before that, she went with her husband to watch movie, and then she went out eating, with her husband, and she had gone for her annual checkup. Next day, when she got her report, and unfortunately there was, metastasis, she was suddenly very devastated, and her whole body and mind was not able to cope up with the news. So again, I think we need to be more understanding how we really need to handle. Let's not be just guided by the Western guidelines, honestly, because their communication is very, very much evolved than the kind of communication we do in our country. But of course, they do help us in improving our communication. But I would still not completely copy paste what they do in my country. That's what is my learning, Vedant, to share with you. Yes, Dr. Harimon, I think you wish to say something, and then Dr. Asha. Go ahead, please.
Yeah, I had worked in a John Hopkins hospital in UAE. So I had experienced that part of it. It was compulsory for us to tell it. And many of them were quite abrupt about it. In fact, they needed to tell exactly the stage and how to go about it in meticulous detail. So there was no use in arguing. It was the way it was.
Yeah.
But in Brunei, it was more flexible. We are lucky to be in India, where we can be flexible and definitely we can discuss with the patient as well as so many of the patients, as you had told, they don't like everything to be told. They tell us, please spare us the details. They're not very happy. Some of them don't mind. Some of them want to know. Family definitely does not want, most of them. But we also know that the patient has got a right to know the diagnosis, and it helps in the treatment also in acceptance. So in fact, I counsel the family first, telling them that they should accept in a graded way. We will do it because we are trained for that, in a graded way, that he won't be emotionally upset because of that. But at the same time, he comes to know of it and he accepts the treatment. So this advantage is there in our country, which is not there in the Western countries. So I think we should be glad about it, and we should use that at the maximum.
Thank you. Thank you for bringing that up. Thank you, both of you. Yes, Dr. Asha, please go ahead.
Yeah, to something what Sir said, we have the advantage of this flexibility. So Paul was talking about his parents. He knows that he'd be better off when his parents know. So I suppose the family knows the patient better. If it is a 90 plus and the family respects, thinks that the parent won't take that news properly, maybe it is better for her to be comfortable in life. If the family thinks that they can take it well, we can break it gradually. I suppose that flexibility is there, we can utilize that flexibility.
And I think, at least from your side, you can try explaining to the family the benefits of disclosure. So in spite of knowing that if they still decide that we don't want the patient to know, I would say we can respect their feeling, we can document, get it signed by them, so that you have that in writing from the family, that they are the one who have decided, and then you are safe, and then let the family take the call. This is what is, but then of course, there's no one line answer to it. You really have to look at the situation and take a call. Thank you for your input, Dr. Asha. Yes, Dr. Mini, I think you have something to add. Go ahead, please.
I just want to give the feedback of two cases that we have discussed here. The first one was the patient who, the bystanders whom they want to take the patient away from my hospital because she had a low platelet. So next day, they didn't take the patient. They brought all the platelets, the donors, and she has delivered uneventfully. Mother and baby is in good condition. They got discharged. The second patient was the second case was about what was the case? Okay, the one thing about the bargaining, in bargaining, when we break a bad news, like suppose your baby has become IUD or the death, it is an intrapartum death, then one way of bargaining the bystanders used to do is they say, no, we want to check again. We want to get the reports. We want to show me they will go and argue with the staff there to get the scan reports, to get the reports. Then we want to take the patient to somewhere else, or we want to show the result to someone, or take online consultation somewhat. And then somehow from there also, once they get convinced the same, they will come back.
Yeah.
And the third patient who was reluctant to get discharged, that patient actually had a tough time with the staff there. They were forcing them to the staff were forcing her to get discharged. They called the parents and all, and they had a tough argument. Finally, I went and the staff was asking, why, madam, you're so soft to this patient? I said, no, better, easy way is to, because I said, now this is the better way of communication. Now I said, I went and I asked, you staff, all the staff be out. I just have a talk with her. I asked her, what is actually problem? Why are not going? And what is there any problem with your family? She said, no. Actually, there is not much, because I thought I will have only just IV fluids and all. My two younger children will be enough. No need for any bystanders. Actually, she was having a quarrel with her husband and their relatives. So I said, no, the staff are, no. Then she said, what pains me is that the staff are behaving very badly. They are asking me to get discharged. Even when I'm not well, I was fainting all the time, and the staff is asking me to go out. Then I told, no, the staff is very considerative, and they are very concerned about your health, because you are alone. And if you fell down in the bathroom, or if you fall, or you get some injuries, then there will be the staff or the whole hospital and the paper media will blame the hospital that we have not taken care. That is why they are insisting on a bystander. So you can remain here as long as you have a bystander. Otherwise, you go home and take rest. And she went home with the advice. Okay.
So all three cases you handled very, very smartly. So good, so good. I'm so happy. So I think communication does have a role to play. If you are able to talk to the patient party, help them understand, like Dr. Hari Mohan has written, most of the families would agree with you. 99% family would accept when we explain. Yes, I think that's what is required. So we fall short of words and explanation. That is where we need to work on, and you can actually avoid those reactions. Wonderful. Thank you so much. Any other point or any? Yeah, Dr. Rajalakshmi, I think you wish to at some point. Please go ahead. Unmute your device, ma'am.
I had a patient who had a growth in the lung. She was 92 years old. So the children didn't want her to know. But then I told them that she would go in for a tracheostomy. She would have to go for a tracheostomy because the growth is rather large. But they said, no, we don't want to do anything like that. We want her to be like this and let her go peacefully. So I explained the situation. So, but then they came back after around 5 months because she was already in distress. She was in distress. She had severe obstruction. So then again, I said, we'll have to go for a tracheostomy, and which they were still not willing. They're still not willing. So we gave some steroids, and then she settled for some time. But then they finally said, okay, please do tracheostomy. Let her at least breathe before she dies. So then finally I had to do, but this lady was so, she was very she knew everything. She kept saying, don't open this, don't open my throat, don't open my throat. She kept saying throat. And once this tracheostomy is over, she said, oh, it's all gone, I'm gone. I'm gone. And the next day she passed away too. That was the saddest part of it.
But I think
So,
I want to say something here. See, what you do in the best interest of the patient, even if the outcome is not as you expected, we have to very mindfully learn to detach ourselves from the outcome. Otherwise, we'll be unnecessarily suffering for any decision that was taken with the best interest in mind, but that turned out to be a wrong decision. So I would say that's a very mindful process, detaching yourself from that. And that's very, liberating also. It's mindful, but it's very liberating because whatever, if you have done with the best interest in your mind, and if the decision goes wrong, we have to accept that we are all human beings and we haven't done anything willfully. That's very important. Thank you for sharing this case. I think, see, we have so many cases coming in, somewhere where we announced and we were okay, with somewhere we did something, we found a wrong, outcome of that. And that's how the life is. So,
Madam, could I just ask Mimi one question, like how would they break the news to an adolescent who gets pregnant?
Adolescent
Gets
themselves,
pregnant?
like the news of becoming pregnant to the patient or to the bystanders, madam?
Both. The patient might be quite, I think she might know.
Sometimes the patient also doesn't know. 12th standard student came here with acute abdominal pain in the casualty, and she was taken. The sister saw some fluid leaking out from her vagina, and she was taken to the labor room. Immediately she delivered, and she denies it, and she doesn't know about the pregnancy. And the mother who was there, I talked to her, say, this is your baby, and she fell down. She became unconscious. So what in such situations, and immediately after, the moment you reveal it to we can't say who might have brought these patients. Sometimes the uncle might have got, and once actually one uncle was there. He has brought the girl, and he said no, she had an affair from Dubai, and from there the boy has made her pregnant, and we should tackle him like that. He was saying, you better discharge the girl, because we want to take her home, be better before others come to know about it. He was in the front to settle the issue. And finally, when the police came, I found that later, when I went for the court, he was the culprit.
Uncle was the culprit.
So some hasty people who are in front, who are pretending to be the settlers, sometimes they might be the. So how to break means first we ask the patient. I don't make any scene of it. I even tell the staff not to create any scene. I even tell the immediately we have to report it to the police, and I tell the police also, don't come in uniform. You come in mufti, you come in, actually that has to be followed in POSCO also. But sometimes these police, they become very fast and they will make a scene in front, and the whole labor room, the whole, it will be some sort of TV social hype also will be there. Media hype also will be there. So first I make them, the patient, I'll ask them, try to get to the patient at that time won't say anything. So I better don't ask anything to the patient at that time. Then I will call the mother and ask her whether she was having an affair or like that. And finally, I'll call to her, call to my room and tell her that this has happened. She will first cry, then she might feel unconscious, and finally she will have, finally she will, I'll make her understand what has happened. I will tell her, don't show the emotions because others will come to know. And you go to your room and take your own time to accept it. And after the bystanders agree to that, then only I'll shift the patient to that room, because there will be a huge exchange of words between them in the room. And then when the police comes, they will be a better mediator between them. So they will be nagging all the questions. Again, the police also will try to get the news, but actually, finally, all those prime reports won't be true. Finally, it will be something else at the end of this thing. And I made one couple marry also after the age of puberty, made them, because the child was sent to the juvenile home, and later, once they were 18 years old, when their age was to get married, they both were made together also.
Wow.
Get in wedlock also.
That's great.
And one person who had come pregnant, 3-4 months pregnancy, came for termination. I said, I don't do unwanted pregnancy termination. I usually don't do. Then I called him. I said, you bring the culprit, the boyfriend. He came. He said, I'm ready to accept her. Then I told him, you come with your parents. I talked to them. And finally got them married, and she delivered actually 6 months, 8 months after marriage. so marriage bureau also I have. provided they are genuine, because if it is both are really interested or genuinely in love, that's, and if the parents do agree, not out of compulsion or pressure.
Thank you so much. I think we had a wonderful discussion around this topic, and a lot of new perspectives actually came in, a lot of new examples, new situations that we have discussed. So it's already, what is it time? 10:10. And we have how many presentations today? Rafiq, I think Dr. Namir also, and
Yes.
3 presentations. Okay. Can I request everyone to stick to 8 minutes limit so that we can finish in, say, maximum 30 minutes?
Okay, madam.
Okay, thank you so much. And I'm allowing everyone to be able to share your screen. Okay, so who will do the presentation first?
Shall I do it?
Go ahead, please. Yeah. Actually, Dr. Namia, you are going to do it?
Reflection and reflective practice.
Okay, so I would request you to, stick to just 8 minutes presentation. Humble request.
Yeah, much less than that, much less. If
Go ahead.
possible.
Go
I
ahead.
will take the advantage.
Okay.
Just go ahead, please.
Okay, very good evening to all of you. And we had a really interactive session for the last few weeks, and we all enjoyed it, and we have benefited out of it. And last Sunday we had a meeting at Trivandrum, and a very good interaction also. And I think we have gained a lot from this interactive session. And even just now we had the topic on revealing of bad news to the patients and the bystanders. So that was very useful. And now coming to the reflection and reflective practice. As a practitioner of more than 47 years of experience, I would narrate 2-3 incidents in my early practice in a rural village. One is regarding one 50-year-old man, because I was doing a general practice at that time, and in the night at around 1 a.m., I was called in to see a patient with acute chest pain and vomiting. And I examined him, and then I suspected myocardial infarction, and asked them to take him to the nearby hospital. And in the morning, I heard the news that that guy passed away. They refused to go to the hospital in the night, and finally had the tragic end. Second was, that time we used to give procaine penicillin rampantly, and this 16-year-old boy, I had to give procaine penicillin, and the patient collapsed. But somehow I could revive the patient, and I was happy. They were all happy. And the third one is a case that was a 15-year-old girl who was diagnosed to have rheumatic fever. And at that time, we used to give benzathine penicillin. And she was taking it regularly. And after a period of time, she didn't turn up for the follow-up. And she stopped the injections. And finally, when she was brought to our clinic one day, she had severe edema, and she had rheumatic carditis, and finally she died. Now, in the backdrop of these three incidents, I had my doubt whether I had conveyed the message to these patients and the bystanders about their treatment and the risk involved. I think we could have, with more communication skills, I could have conveyed this message to these patients and saved them from these embarrassments. Now, coming to this reflection and reflective practice. Reflection means analyzing one's own experiences to improve the way one learns or works. And it's a valuable skill. It can help the learners and the professionals gain experience, confidence, and self-awareness. And we have seen reflective people, they always reflect on things, that is, look back and things that have been done or said in order to think calmly and quietly about them. And reflective thinking is the notion of awareness of one's own knowledge, assumptions, and past experiences. And now regarding the educational theories of learning, there is one Cobb's learning cycle. That is, you look at the experience, that is the actions, past and present, and then go to the observation. You have to document what has happened, and then you reflect on that, making sense, investigating, theorizing, and then planning for the future, making plans in order to take further action. And this is one way of reflecting. And why reflect? That helps in deep learning, that is rather than superficial learning, and then achievement of expertise rather than a competent practitioner. And we have two models of reflective practice, that is the Gibbs model and the Peters data model. This Gibbs model, one of the most famous cyclical models of reflection, leading you through 6 stages of exploring an experience. This description, feelings, evaluation, analysis, conclusion, and action plan. And this was developed by Graham Gibbs in 1988 to give structure to learning from experience. And it offers framework for examining experiences and gives its cycle nature lends itself particularly well to repeated experiences, allowing you to learn and plan from things that either went well or didn't go well. And the second one is the Peters data model of reflection, and that consists of 4 stages. And one is describe, second is analyze, third one is theorize, and fourth one is act. And for strategies for reflective practice, you can have portfolios, discussion groups, essay writing, and critical incident analysis. And so from this brief talk, I would like to draw your attention to the importance of reflective thinking and learning from our past experiences and rectifying our mistakes and planning for the future. Thank you.
Thank you so much, Dr. Nambiar. You did not share your presentation.
Didn't share?
You did not share your presentation.
Sorry, you heard me talk?
Yeah, we could hear you talking, but I was wondering, but I didn't feel like stopping you in between. So what
some problem with my video.
No, we are not even able to see you. Your video camera is, I don't know if it's on. But it's okay. What I will suggest,
okay,
share your presentation in the WhatsApp group. Let everybody have a look at the presentation.
Okay.
Yeah. Thank you so much.
Okay, thank you, ma'am.
Thank you. So I think you actually completed in 8 minutes.
Okay, thank you.
Yeah, rather less than 8 minutes.
Yeah, so, I promised.
Yeah, as promised. Yeah, thank you so much. Yeah. So second, we have the next presentation. Yeah, Go ahead, please.
Yeah, Rafiq, are you doing it or I will do?
Yeah.
Okay.
You are able to see my.
Yes,
are you
we,
able to see?
yes,
Yes.
Okay.
Yes.
So I'll be talking to you one of the most important, important pedagogy, that's the demonstration, and also about the debriefing. So demonstration, if you ask for a definition, it's a process of teaching someone how to make or do something in a stepwise manner. So it can be experiment in the lab, demonstration, or a procedure like a CPR for a group. It also can be to a patient or to the bedside, demonstrating how to do an incentive spirometry, or teach them to do it at home like a spacer. So all these comes under demonstration. So in simple words, it's showing the students how to do something. So there are a few stages. There's the explanation phase, demonstration phase, student performance phase, instructor supervision phase, and evaluation phase. So from this picture, you can know it is something to do with the defibrillator he is going to demonstrate. So you can start with an explanation how to do it, switch it on and take the paddles, put the gels onto it, and then apply on the chest and charge and give the shock. And also you can demonstrate it later. At the same time, you can have a commentary on that. That means like explain to that. Then later you can tell the students to perform it. So this is a typical example of a student performance and instructor supervision. You can see the instructor there and student doing an intubation, and all the students are watching. And this is an evaluation part. So it can be also used as an evaluation tool. You can see the students are taking the BP and the evaluator there. So like when you are preparing it, you should have a proper planning and a good preparation. You should, as Madam always says, should practice beforehand, and all the participants should be able to see the whole procedure, and you should stress on the main points so that it will be instilled into the brain. And always interact, ask questions, and also to encourage questions. That is what we have to do. And finally, summarize. So if you ask the advantages, it stimulates the interest, so more attentive than a lecture will be taken, and they develop observational skill, psychomotor skill, and communication skill, and it will be always retained in the memory. And also it can be used for evaluation. Disadvantages, it's time consuming. It's because it's done for a small group, not beneficial for a large group, and the faculty overload, like will have more work to do. And the high instructor student ratio, they say for 10 students, there should be one instructor. So these are the advantages. This may not be very familiar term to you. It is debriefing. Debriefing. You all would have heard the word brief. So this is debrief. Briefing is what like Madam used to do. Like she used to tell about the role plays, and she used to tell what to do to each of the person. So that is a briefing, and debriefing is something which is done after an activity is done. So briefing is before an activity, and debriefing is after an activity. In this, I'll just show a role play.
What happened, brother?
I will not, because it is a 7 minutes time. I'll just show
There's no
a few
pulse, there's
seconds.
no breathing. You start the compressions, I'll call the code blue. Code blue activated in neighbor room. Right, code blue has arrived. You continue with chest compressions. Can you tell me the history? Mom, we just gave her antibiotics. We were about to think of it.
So I just stopping it to say that that was a role play which was there, and you could see the different team members in that. So like after a briefing of this, and they are asked to do the role play. So after that, the part is the debriefing. So the debriefing, the term, it has come earlier. It was practiced in military where soldiers were called, and after any mission, they had a meeting and they used to ask them like what went well and what did not do, or what better we could have done. So these are a conversational session of sharing and examining the information which follow after a specific event has taken place. So it is something like kind of a feedback. So providing performance feedback, but it differs from the feedback. It is like feedback is given by the facilitator, where the learners are not asked any questions. But here the learners are asked what went well, what better you could have done, what you have forgotten, and how you can improve it. So these are the questions will be asked by the facilitator, and will allow the students or the learners to speak. So this is the one. Now this is a simulation being shown here, and in medical education, debriefing is more done for this debriefing purpose. You can see the facilitator, you can see the learners. So after an act, they are discussing on it. So like the learners will be able to correct themselves during the next activity. So, and all the learners will be asked about what went well with them. So it is something like a reflection. So this is another picture which is showing a trauma to a patient, and finally they are having this debriefing. So these are the questions will be asked: how did it go? What went well? What did it? And what can we improve, and how do we can make it happen? So it is basically the reflection and correction of the same, and it's a learning from the experience. This is a video where a debriefing is done. You may not be able to hear the audio properly, but I can explain.
So once again, what went well for this scenario? We're talking to each other. Good communication between team members. Communication. Some things got moved that you weren't aware of. So what does that tell you then? What does that tell you about orientation to the environment?
No, nursing is to say this is where that's at.
Or
just kind of,
or when you walk in a room, any patient room, just a quick gestalt of like where things are, because you know what you're coming in to do.
Yeah.
Usually, so you're looking right away for what do I need to manage this patient? Okay, where is it? So just a thought. Anything we forgot?
the CPR board.
The CPR board. Yeah. And although it takes you a second or two to put the head of the bed down, do it.
Okay.
Because you gotta have that head of the bed flat. And then
There's not a quick.
I know, I wish there was like
a quick
I don't think there is. No, not on these beds. So you do have to take that second.
So would I put the CPR board under her, or would I give it to Sarah?
That makes no difference as long as it's brought to their attention.
If you're already coming from up there, there's no reason why you need to hand it over her. So just, you know, CPR board and you just in turn. Yeah.
Good idea. Good idea.
So that was one the debriefing what you had seen, and she was asking like what went well, and they are saying about that communication was there between us. And then the another question was asked was what went wrong, or what did you forget? So they are coming with the answers. They said that we forgot to keep the CPR board. CPR board is something like when you do a chest compression, you keep under the patient so that the compressions are effective. Otherwise, because of the mattress is there, the compression will not be effective. When you press on the bed, it will go down. So that is a CPR board. So these are the things they discuss, and during the next act, it will be much better. Their performance will be much better. And this is a video debrief where they are showing the photos to the learners, and they can see themselves, their body language, how did they behave, and they can reflect on these things and given a chance to improve so that the next activity will be much better. So debriefing is a simple yet powerful tool which enables the participants to reflect on what happened and why it happened. And so the gaps in knowledge and performance are identified and closed through discussion. So since it is done immediately after the activity, all the events will be still fresh in the mind of the students, so they will be able to recall it. And always a trained facilitator guide the participants through this reflective process. So, and finally, to conclude, that you have to summarize the lessons learned, and all these learning points, what you learn should be incorporated for your future practices. So what to expect in debriefing, it facilitates the recall and insight, clarifies learning points, builds self-confidence, and improve the performance. So this I just shown, like we all have done our now after Rafiq, like it will be complete. All we have done. How many of you would have gone to the video what Madam said and seen our performance? So that is one sort of a thing. So I think most of you would have done, and you could have realized what went well and how you felt about it. And you can always discuss with others, even if it is a group, and what went well and how can I improve. So this is one way we can improve ourselves in even your presentation also. So thank you for your kind attention.
Thank you, Dr. Paul. I think it was a wonderful presentation and very well covered through discussion and videos. Thank you.
Thank you.
Yes. Dr. Rafiq, go ahead, please.
Can you see my screen, ma'am?
Yes.
Everybody?
Yes, Rafiq.
So all of you can see now. So what do you see in this image? Please unmute and respond, please. Am I audible?
Different expressions.
A girl smiling.
Child, smile, changing smile technology.
Are they one and same, or they are different person?
The same.
Same
Look like different.
Could be sisters. Could be sisters.
Okay. Okay. They are not same. Can you identify the differences?
Yeah,
Teeth alignment.
Teeth are different.
Very good.
Nose is different. Nose is
Partition. Hair partition.
Good. Okay.
I think smile is different.
Okay, very good. Although they may appear similar at first glance or in certain aspects, they're actually completely different individuals, right?
Yes.
So the same is applicable in case of some certain drugs, especially certain emergency drugs, high-risk drugs. See this example. So see, these the one is phenylephrine and the other is neosporin, but they are almost similar to see, right? And this is two drugs, verapamil and naloxone. They are also similar in appearance. And another example is heparin sodium and midazolam. And the last one is 25% dextrose and mannitol. So they are called lookalike drugs. Okay. So today's my topic of presentation is medical errors due to lookalike and soundalike medicines. Actually, this was a few slides from one of my presentation which I did in my hospital, and this is just to introduce my topic here. So, did you like my presentation on medical errors due to lookalike and soundalike medicines?
Yes.
Okay. Can you name which pedagogy I used in that? That is puzzles. Okay. Are you interested in puzzles as a pedagogy in your presentations?
Yes.
Yes.
What all puzzles you know?
Crossword puzzles.
Jigsaw puzzles.
Good.
Crossword puzzles.
Okay.
Life is a puzzle.
Pardon?
Life is a puzzle.
Okay. These are the list of different types of puzzles. Rebus puzzle, deductive thinking puzzle, observation, and a lot, almost 10-12 types of puzzles are there. Okay. So
what are the advantages? Can anyone say what are the benefits of using puzzles as a pedagogical tool? It will
very engaging.
Yeah, it is very engaging. It will help in engaging students. It will encourage critical thinking and
problems.
Yeah, it promotes active learning and student engagement, and it enhances retention and understanding of concepts. Okay, and again, it fosters collaboration and teamwork. So, solving these puzzles, it will help to build the teamwork. Okay, these are different types of. I will give some examples. This is a rebus puzzle. This is an example. What is this? Can anyone say?
Chance.
Chance. No, not just chance. Something is hidden in there.
Fat chance.
Yeah, it's fat chance. What is this? This is show. Show is written.
Sideshow.
Okay, good. And what is this? I can give you a clue.
Operation.
Yeah, not just operation. What is missing
silence? Omerto is silence. Don't tell. Mafia word. Omerto, don't let the secret out.
Okay, go. Yeah. What is missing from operation? What all letters are missing?
P, A, I, N.
Pain is missing.
Pain.
That is a painless operation. Okay. And about thinking puzzle, it's like giving a scenario like Sherlock Holmes stories and asking for a solution. The solution and observational power. Can you point out the odd one? Can anyone say?
Rightmost second row.
Second row.
Very good. This is correct. Okay. Spot the mistake in picture. Anybody?
The word mistake.
No.
No mistakes.
Yes.
Can you find the mistake?
Oh, third and twice.
And another type is mental and visual skills. Find the differences. Okay. This was I introduced in my first. Okay. How to use puzzle as a pedagogy. Present. I will explain with my presentation as an example. Present the puzzle related to topic you are introducing. I was introducing lookalike. I want to introduce the topic lookalike drugs. So I use this pedagogy of mental and visual skill. Okay. Then present in such a way that it can grab the student's attention. I don't know whether I succeeded in this, but I suggest you all should do like that. And next is analyze the puzzle together. If it is not like this, if it's like Sherlock Holmes style of question, then you have to analyze the puzzle together with students. Break down the problem into smaller components and discuss the possible strategies and solutions. Then encourage students to think critically and share their ideas. And gradually transition from puzzle topic to the topic you want to introduce. Actually, as I did, it was actually I wanted to introduce the lookalike drugs. The transformation was like this. The same is applicable for medicines also. So I introduced my topic like that, and highlight the similarities and connection between the puzzle and topic the same, and use the puzzle as a bridge to main concept. So in order to grab the attention and keep them engaged, use the puzzle and gradually introduce your main concept. And present the overview of the topic and using the puzzle as a context, and briefly outline what main concepts and objectives. Explain how the puzzle relate to the broader subject matter. Discuss real-world applications of the topic and share examples or case studies that demonstrate its relevance and highlight the benefits and potential impacts. For example, after this thing regarding lookalike drugs, I can share this information according to JCA. Medical errors ranked as the third leading cause of death in the United States. I just copied from ma'am's slide, and it is crucial that we all should exert all possible effort to prevent such fatalities. One effective measure to reduce occurrence of medical errors is by strictly adhering to protocols concerning lookalike drugs. Like this, after introducing your topic proper, you have to tell them what is the real life significance of your topic. And drawbacks, the certain drawbacks are also there. It has got limited application only, because even though it focuses on problem solving skills, it may not be applicable in a broader term. And next is lack of context and potential for frustration. Certain students, if they can't handle solving this puzzles, it may lead into frustration, and a limited feedback only will be available with puzzles, and it requires a lot of passive learning also, and narrow focus on specific skill. Even though it focus on problem solving, it may not be focusing more cognitive skills, and definitely it will be time consuming when especially like that deductive thinking type of puzzles. It may be a lot consuming a lot of time. So, and potential for superficial learning. Some students will be very much interested in solving puzzles, but actually they may not following what exactly we meant by what is the real topic we were interested in. So they will be engaging in puzzle solving only. So it will lead to only superficial learning. So in summary, puzzles are one of the widely used and strong pedagogical tool, highly effective in engaging students in the learning process. And finally, one more puzzle for you. You are driving during a bad storm. You pass a bus stop with 3 people: the love of your dream, your good friend who once saved your life, and a little old lady that looks very ill. You have 1 free seat. Who do you offer a ride and why? It's a question for you.
I know this.
You go out and let
the
friend and old lady go.
The old lady was very ill. So
okay.
So you send your friend with the old lady, and you
Yeah.
Very good.
You don't drive in a bad stop.
Fantastic answer. Give the thing out of the box and give the car to your friend and ask him to take the old lady to hospital.
You can dream yourself at that
Yeah.
calmly.
Thank you.
Thank you very much. I think it was a wonderful presentation. I can't see my video. I don't know where I am. Am I visible to you?
yes,
Yes.
madam.
Yes, ma'am.
But how come I'm not visible to myself? Okay. I think there was some change in this setting. I'll not hold you further. I know it's already 11:15. It's almost 4 hours.
7:30 we started.
Oh my goodness. 3 hours.
Yes.
Past 3 hours. My
Past
goodness.
3 hours. 3 hours.
Hats off to your patience and your stamina to sit along. But thank you so much. I think it was a wonderful discussion we had. Everybody brought in a lot of their experience and their learning that we all shared with each other. I'm closing the session here. Feedback form is shared in the WhatsApp group. I request you to give your feedback, not about the presentations made by the participants, but about the topic.
Already
Yes,
sent.
Mr. Paul, I think you want to say something. Go
Yes,
ahead.
actually, request. We would like to. I would like to see you breaking a bad news.
So we'll do one thing. The next one is quite related. The next topic is quite related, which is disclosure of medical error, because medical error is also a bad news.
Bad news.
So maybe we will start with the role play. If you want me to do, I'll be more than happy to do that, and then we have the discussion about it. Is that okay?
Yes.
Thank you, ma'am.
Sure.
Next is 7:30 or if it is 7:30, it will be better actually.
Yeah.
If everyone is agreeing for it. I don't know about madam.
Yeah, I'm
Next
okay.
is,
I think 7:30 is okay. Yeah. Especially it will be the last session.
Last
And I'll
session,
be-
so,
Yeah.
yeah.
And I'll be requesting all of you to give your feedback. So kindly prepare what feedback, whatever feedback you want to give about the, so that will be video recorded. Yeah, like the camera will be on you and you will be
We
giving
will
maybe a
be-
minute, not a very long one, a minute feedback from each one of you. 30 seconds.
We will also be requesting you to continue for another 2 sessions.
yeah.
Sure, sure. And also, I think I had requested Dr. Vasudevan to talk about the ethics in
Ethics, yes.
yeah, a short, maybe
It's
half
ethics,
an hour.
man.
Yeah, maybe 30 minutes kind of a presentation for, for everyone's benefit. Yeah, for everyone's benefit.
Next class or?
Next class. Yeah, actually, I have to leave tomorrow morning, early morning to Pune. So I have still to pack and do so many other things.
Yeah.
Pardon me for being in hurry, and I'm tired also. I've just had 4 hours sleep.
Take rest.
Thank you so much, everyone. I think
Okay, thank you, madam.